review and annual performance review and orientation for appointed regional heads of pharmaceutical services. And the theme for this performance review is orientation, reorientation, or reorienting pharmaceutical services towards primary health care for accelerated progress towards UHC and the health-related SDGs. So to kick off the meeting, you want to know the people that have joined in from the beginning of this meeting. So I will begin from the Office of the Director of Pharmaceutical Services, Ghana Health Service. My name is Dr. Edna Knight, and I am a senior pharmacist, a senior specialist pharmacist at the Office of the Director of Pharmaceutical Services. With me here, we have Dr. Manuel Owusu. I'll let him introduce himself. Also, please go ahead.
All right. I'm Dr. Emmanuel Owusu, Deputy Chief Pharmacist and Officer Office of the Director of Pharmaceutical Services. Thank you.
Okay. In the physical office, we also have the Director of Pharmaceutical Services. I will not let him introduce himself now. I've introduced him and he will be introduced properly when he's about to speak. Also online, we have two of the officers. We have Dr. Bright Omeku, who is currently engaged in official assignment, but he's online. And then we also have Dr. Claudette Diogo, also online. So the full office is online participating. So with that, I will kindly ask that you unmute your mics, tell us your name and the region you are tuning in from, and also the facility. Thank you.
Good morning, Ms. Gifty Ango, the Acting Chief, Greater Accra.
My name is Happy Smart, Head of Pharmacy, Shao Sudoku District Hospital.
Good morning. I'm Chief Dr. Poko Kabnokai. Uno is ready.
Good morning. Dr. Felix Edopa, Chief Pharmacist, West Region.
Good morning.
Good morning. Kwame Crime, Uno Directorate, Chief Pharmacist.
Good morning. I'm Dr. Mrs. Grace Atejapon, Specialist Pharmacist and Health Greater Accra Regional Hospital.
Good morning. I'm Rita Owusu-Donko, Chief Pharmacist, Ashanti.
My name is Aina Ofenda Champon. I'm the Chief Pharmacist, Central Region. Thank you.
Good morning. My name is Farm Dr. Philip Poku, Acting Regional Chief Pharmacist for Ahafo.
Good morning.
From there.
Good morning. I'm Solomon Obiri, a newly appointed Chief Pharmacist and currently at the Eastern Regional Medical Store. And I'm here with the Deputy Chief Pharmacist, Amedonu Dankwa. Thank you.
Good morning. I'm Andrew Skabu, Peki Government Hospital, Head of Pharmacy, Volta Region.
Good morning. I am from Kwekuti Kujesibiku, Head of Pharmacy, Yaso Desho Hospital, Asante Achen South, Ashanti.
Thank you all very much for that self-introduction. I see a
Good
few.
morning.
All right, go ahead.
Good morning. I'm Frank Osehajiman, Specialist Pharmacist, Head of Pharmacy, New York Jersey Government Hospital, Ashanti Region.
Good
Good
morning.
morning. I'm Ole. DDPS. Ashanti.
Good morning. I'm Eko Isel Asford, Offenso North District, Head of Pharmacy for King Kenso Government Hospital, the District Hospital. Thank you.
Good morning. I'm Gifty Ogo, Bogoso Government Hospital, Head of Pharmacy.
Good morning. I'm Felicia Sena Edu Jemshi, Head of Pharmacy at Numaso Government Hospital.
Hello, I'm Daniel K. Kwam, Specialist Pharmacist of Upper West Regional Hospital as the Head of Pharmacy.
Thank you all very, very much for tuning in, and we are very excited that we're having heads of pharmacists, healthcare pharmacy from all over the country join us this morning. Honorable Chief, you are most welcome. I can see Auntie Martha on call. Probably she's indisposed at the moment too. So that we are blessed to have Auntie Martha join us. Okay, so going on with our program this morning, we have the Director of Pharmaceutical Services, Ghana Health Service, with us, and I believe we all know who he is. Do we all know him? Apart from our chiefs, pharmacy heads that have joined us this morning, please, do we know who our Director of Pharmaceutical Services is?
Yes, please. We do.
Okay, Mr. Frank, say, please, who is the Director?
Dr. Dominic Ochikosa.
Excellent, for 10 points. Thank you very much. Yes, so that is our Director, Dr. Dominic Ochikosa Ochri. So without much ado, I will give him the mic to take over and give us the opening or welcome address. Thank you.
Okay, so thanks so much, Dr. Edna, for that nice introduction. Good morning to us all. We were expecting more than this. We are only about 34, we are less than 40. 44 for now. We are expecting more to join in. If not for anything at all, we expect the heads of the regional medical store who are pharmacists, and also the heads of the regional hospitals and all heads of district hospitals to join in this very performance review meeting. And I've seen quite a number of chief pharmacists, but it's not complete. I've not seen Upper East. I've not seen OTs around, knees around. I've not seen Western North, Savannah, Volta, Okay.
Director, Western Office here.
Western Office. Okay. All right. And I've also identified a number of the newly appointed chief farmers. I've seen Seth Chum. So Monogre has introduced himself. Kwam also introduced himself. And then Chief Painting. And Lynn. All right. So good morning, Auntie Martha. I know you are online, but you're not speaking yet. A very big good morning to you. On behalf of the Director General of Ghana Health Service, I extend warm welcome to us all as we gather for this critical performance review and orientation section. This is not just another meeting. This is a defining moment for pharmaceutical services in the Ghana Health Service, which remains the largest service delivery agency of the Ministry of Health. As we've already noted, the theme for this year is reorienting pharmaceutical services towards primary health care for accelerated progress towards universal health coverage and the health-related sustainable development goals. And this theme is both a vision as well as a mandate. When it comes to the presentation, we try to explain why we chose this theme. But like we are all aware, the universal health coverage cannot be achieved without strong pharmaceutical services. We must ensure that every Ghanaian, regardless of where they live, have access to quality, safe, and affordable medicines, and also use them responsibly, especially at the primary healthcare level, where the majority of our people seek healthcare. The theme also reflects our obligations towards the residents of Ghana. It is in essence our reason for existence as a profession. This reorientation demands that we shift from being reactive to proactive, from periphery to central, from invisibility to indispensable in the health service delivery system. Pharmaceutical service must be integrated into every level of service delivery, particularly at the community and primary healthcare levels where impact is greatest. Excellence in pharmaceutical services for this office rests on 7 interconnected pillars. These are not optional. They are foundational to everything that we do. And this includes leadership, adherence to policies and standards, planning, monitoring and supervision, feedback, and regular meetings like we are doing this morning, data management, continuous learning, and teamwork. These pillars are mutually reinforcing. Strengthening one amplifies the others, and weakness in any compromises the whole. As we review our 2025 performance, we must earnestly assess ourselves against these standards. Maybe let me take time to talk about leadership a bit, which remains the key cornerstone of pharmaceutical service. And I want to speak directly because it is the first pillar for a good reason. The reason being that without visionary, principled, and courageous leadership, we cannot achieve our goals. Leadership in pharmaceutical services requires more than technical competence. It demands strategic thinking, uncompromising integrity, resilience in adversity, and the ability to inspire and mobilize others towards a shared vision. Each of us, as regional heads, are architects of change, regardless of standards and guardians of standards and champions of pharmaceutical excellence in our respective regions. Your leadership will determine whether pharmaceutical services are being seen as essential or peripheral, whether we contribute to improve health outcomes or merely exist as a checkbox in the system. Colleagues, I must absolutely be candid with us that the past year has been one of significant progress, but without profound challenges. We have faced existential threats to the integrity and autonomy of pharmaceutical services within Ghana Health Service and without. As many of us know, the recent attempt to decouple medicines management or pharmaceutical logistics management from pharmaceutical services was not only grounded in law or legislation, but was also an existential threat. Pharmaceutical logistics management is an essential and integral part of pharmaceutical services. And I repeat again, that pharmaceutical logistics management is an essential and integral part of pharmaceutical service. And I've always maintained that he who controls the pharmacy stores controls pharmacy practice. For one reason or the other, I also think that we shouldn't draw the wrong conclusions. But what happened is indicative of the fact that times have changed. We can't continue to do old things and expect new results. Like Peter Drucker once said, the riskiest thing is to do nothing new or to do new things in old ways. We must continue to accept our professional competence. We must demonstrate through evidence and action why pharmaceutical services must be led by trained pharmaceutical professionals. And this brings us to the subject of the need for us to re-strategize. This annual performance review is not just about statistics or data review or validation. It's about demonstrating impact, leadership, and irreplaceable value. In response to these challenges, we have taken several strategic actions as part of our broader restoration agenda. The first being roping in experienced pharmacists who are battle-tested into critical leadership positions at the regional level. The recent appointment and reassignment of regional heads of pharmaceutical services by the Director General was about ensuring that pharmaceutical services was led by individuals with vision, with expertise, credibility, and courage to navigate these turbulent times. These experienced leaders bring institutional memory, strategic acumen, professional networks, and the gravitas needed to build alliances and advance our agenda at the highest levels in the health system. In relation to this strategic reassignment, I must also say that we have moved some chief pharmacists from one region to the other, and this serves multiple critical purposes, and that is repositioning our best minds where they can have the greatest impact. So if you are moving in from Upper West to Greater Accra, you must know where we've moved. If you are moving in from Western region to Upper East, it's because there is a reason for that, and there's a need for that. These are difficult decisions, but they are necessary. We are in a battle for the soul and the future of pharmaceutical services in Ghana, and we expect each and every one of us to contribute our quota. We must deploy our human resources strategically and decisively. Pharmaceutical services, just like the rest of Ghana Health Service, must be able to relate as one corporate body with the same mission and vision. And going forward, we shouldn't be surprised if we see the assignment of colleagues from headquarters to the regions and vice versa. In relation to strengthening governance and policy frameworks, we are working to strengthen our policy frameworks, standard operating procedures, and governance structures to ensure that pharmaceutical services are not only vulnerable to arbitrary decisions and encroachments. This includes the updating of pharmaceutical services operational strategy, clarifying reporting rules, strengthening supervision systems, and ensuring that all regional and facility level pharmaceutical services are adequately resourced and supported. Let us ask ourselves this question, colleagues, that this review is not an annual ritual. It is a diagnostic moment in the time for us to ask ourselves questions, hard questions. And some of the questions are that, are we visible and impactful in our regions, or we are operating in shadows? Are we demonstrating leadership, or we are simply managing? Are we collecting and using data to drive decisions, or we are flying blind? Are we building strong teams, or we are working in isolation? Most importantly, are we making a measurable difference in the lives of patients and the performance of health facilities? Excellence for this is not negotiable. We must hold ourselves and each other to the highest standards. We must confront uncomfortable truths and make necessary changes. As you present your regional performance over these 2 days, we urge you to be honest, reflective, and forward-looking. Celebrate success, but also acknowledge challenges and articulate clear action plans to overcome them. To our newly appointed chief pharmacist, I want to say welcome, congratulations, but buckle up. You have been entrusted with significant responsibility. This orientation is designed to equip you with the knowledge, tools, and networks you need to be successful. Kindly pay key attention to the presentations from your colleagues. Learn from their experiences, their successes, and their struggles. Ask questions, seek guidance. You are not alone. But remember, with this position also comes accountability. Your region, the health facilities, the health workers, and ultimately the patients are counting on you to deliver pharmaceutical services with excellence. In conclusion, I want to say that, colleagues, the journey ahead is demanding, but it is filled with opportunity. We have a clear theme, a solid operational strategy, committed leaders, and a united team. And here I want to thank so much our predecessors, especially Dr. Pham Jansa Matalitot, for laying a strong foundation for pharmaceutical services in the area of policy development and operational guidelines. I also want to pay tribute to my predecessor, Dr. Bismarck Ededepon, for the good work that he did to establish the office at headquarters. What we did now is execution. Disciplined, relentless, excellence-driven execution. Let us see these 2 days not just as to review the past, but to chart a bold course for the future. Let us leave this meeting with renewed commitment, shared understanding, and concrete action plans. Thank you, and I wish to wish all of us a productive, transformative, and successful annual performance review meeting. May God bless our work. May God bless pharmaceutical services, and may God bless the Ghana Health Service. Thank you very much for your audience.
Thank you very much, Dr. Dominic Otchere, Director of Pharmaceutical Services, for that warm welcome address. A lot of thoughts-provoking messages in there, and I hope we've all taken notes. One thing I took note of is that the riskiest thing is to do nothing new. So we are in a new era, and I hope with all the messages he has shared with us, we're going to do something new to make pharmacy visible and impactful enough. Thank you once again, Director. Okay, on that note, we will move to the next item on the agenda, which is a presentation by the Office of the Director of Pharmaceutical Services. And that presentation, once again, will be taken on by the Director himself, Dr. Dominic Ochu. So, Director, the floor is yours.
So thank you so much, Dr. Edna, for once again laying the foundation for me to build on. And I'm most grateful to you for all the effort you put in to bring us this far, Dr. Edna. And the good Lord will literally bless you. So this morning, I'm going to walk us through data we've received from the regions for the year 2025. Interestingly, most regions will not submit their data on time. So you realize that there will be a lot of gaps in the data. But we also expect that during your presentations, you try and fill in those gaps. I've also realized that we are about 72 now on the platform. Information reaching me indicates that some regions did not share the link we gave them, the program outline and the flyer on their regional platforms. And I will urge all of us to do that if we have not done that. So this morning, like I said earlier on, the theme for our 2025 annual performance review meeting is reorienting pharmaceutical services towards primary healthcare for accelerated progress to achieve universal health coverage and its health-related sustainable development goals. We are all aware that the sustainable development goals is supposed to end in 2030. We are currently in 2026. It then implies that we have less than 5 years to go. And it means that we have to do something extra in order to achieve that. To achieve that, we need to reorient pharmaceutical services towards primary healthcare because primary healthcare remains the chief cornerstone of Ghana Health Service. In fact, we adopted primary healthcare concept as far back as 1977, before the Alma Mater Declaration. Apart from that, primary healthcare is one of the key flagship programs of the government of Ghana. And for Ghana Health Service, all we do is to implement approved national policies. We don't develop policies, no. We implement approved national policies. So in as much as the government of Ghana is not championing free primary healthcare, we as pharmaceutical services have no other option but to realign with this key policy initiative. So that explains our theme for this performance review meeting. And this is supposed to be our presentation outline. It's basically about 10 sessions. And I will play with us to listen carefully. So by way of introduction, what I want us to bear in mind is the fact that Ghana Health Service remains the largest service delivery agency of the Ministry of Health. And the service for now stands also at the forefront of national efforts to achieve universal health coverage for all residents in Ghana. Pharmaceuticals and health technologies, we know, remain the most powerful and cost-effective interventions available to the health system. But their centrality to health system strengthening is unequivocal, as enshrined in the UN Sustainable Development Goal Target 3.8, which seeks to achieve universal healthcare coverage by ensuring that patients that seek healthcare are protected from all financial risk. Our patients have access to the complete spectrum of health service, it being promotive, preventive, curative, palliative, or rehabilitative. And I also want to speak to the fact that this theme of ours is also aligned to our national medicines policy and also our national health policy for 2020. I must here pause and then try to draw our attention to something, to the fact that the medicines value chain that pharmaceutical services seek to address is endless, is so vast, but the World Health Organization in 2020 decided to summarize it. So in the simplest form, it consists of about 7 to 8 key steps, and pharmaceutical service must seek to address all these aspects of medicine service, of the pharmaceutical value chain. Interestingly, we've limited ourselves as a profession usually to the area of dispensing and procurement. But pharmaceutical service, you go beyond that. You have to address all the key areas of pharmaceutical services. The schematic diagram we provided in this very session gives us an overview of the landscape of pharmaceutical services in terms of governance, in terms of resource production, in terms of sustainable economic support, in terms of organization of services, and in terms of service delivery. What this diagram seeks to bring to attention, or seeks to bring to the fore, is the fact that pharmaceutical services is embedded in the framework that have so many stakeholders. Each of these stakeholders have their mandate and their objectives as well as their interests. And as pharmacists managing the public sector, you must seek to address all aspects of the components of pharmaceutical service. In relation to our mandate, we exist primarily to ensure that all the residents of Ghana have access. And when I mean access, I make reference to equitable availability and affordability of essential medicines for all the residents of Ghana. Of course, pharmaceutical service also exists to ensure that all the residents of Ghana also have access to quality, safe, and efficacious medicines across the entire supply chain. And that is the reason why we can't leave pharmaceutical supply chain in the hands of people who have not been schooled or educated or properly trained to manage medicines. And not only that, we also exist to ensure that medicines are used in a cost-effective manner by both consumers and professionals. And doing so, we have to promote therapeutically sound use of medicines. And of course, that explains why we can also leave pharmaceutical service in the hands of people who have not been schooled to manage medicines. In doing this as an office, and also at the regional level And at the hospital level, we provide leadership and direction in the delivery and management of pharmaceutical services. We also facilitate smooth implementation of pharmaceutical policies, programs, and strategies across the Ghana Health Service. And here, once again, I want to pay glowing tribute for Dr. Tensa Mataluto for the effort that she made in terms of policies to facilitate the delivery of pharmaceutical service at all levels. And the third is that we also provide technical advice to management at all levels, so that if you are at the district level as a member of management, if you are also at the regional level as a member of management, if you're also at the national level, you are supposed to advise your management on the delivery and management of pharmaceutical services. Let me pause here and then try to walk us through some of the challenges which have bedeviled pharmaceutical services for long. I've dubbed the 7 demons of pharmaceutical service. And this includes weak governance and management structures of pharmaceutical services, especially at the national and sub-national levels. The second being inadequate pharmaceutical service personnel across all facilities and regions, we will see along the line. Unsustainable developing drug fund, which affects medicine availability. Of course, acute shortage of priority medicines at all levels of care. Inadequate use of priority medicines by prescribers and consumers. And the third being, the sixth being poor patient safety and drug quality measures at service delivery points. And finally, unreliable pharmaceutical services data for evidence-based decision making. In addressing this, the office identified 6 priority areas. The first being governance and efficiency. The third being building our workforce, the pharmaceutical workforce. The third being enhancing access to quality medicines. The fourth being promoting the rational use of medicines and patient safety. The fifth being financial sustainability. And of course, the last being enhancing data management across all levels. I would want to pause here and walk us through the organogram that we currently use at Ghana Health Service headquarters. And of course, on top there is the Director General and of course, the Deputy Director General of the service. Right beneath the DG is the Director of Pharmaceutical Services. This by extension brings to the fore that at the headquarters level, we have direct access to the presence of the Director General of Ghana Health Service. Initially, it was through the Director IC, and with the appointment of the Director of Pharmaceutical Services, now we have direct access into his presence. And that also implies that whatever proposals, whatever things we want to do, we don't need to pass through anybody to get it done on our behalf. You would also realize that we have developed 3 key departments in the office. It was part of the restructuring process. The first being the Department of Pharmaceuticals and Health Technologies, which basically seeks to manage all aspects of medicinal products within the service. And as this department, we have 2 key units: essential medicines and health technologies, and pharmaceutical financing management unit. We also have pharmacy practice and development department. This has 4 key units. The first being pharmaceutical care, the second being medication safety and quality improvement, the fourth being drug information unit, the third being drug information unit, and the fourth being pharmacy workforce management and development. And finally, we have the pharmaceutical policy management and research department, which also has 2 key units. The first being pharmaceutical policy monitoring evaluation unit, and the second being research development and innovation unit. Right. The organogram we've also shown here provides a framework that coordinates all activities of pharmaceutical services, not only at the national level, but also at the regional level. The purpose for this was to ensure that the national and the region work hand in hand so as to ensure the efficient delivery and management of pharmaceutical services. So the regional hospitals, the district hospitals, the health centers, and the CHIPS compound, what we are saying is that we want to experience the effect of pharmaceutical services at all these levels. Likewise, in the management of the regional medical stores, as well as our production unit. And you see the bar, the horizontal bar between regional and the national level. It basically gives you the interrelationship between these 2 units. Information flows freely from the region to the national level, and of course, from the national level to the regional level. So there's nothing like operating in silos or having vertical programs within pharmaceutical services. Our services are supposed to be integrated at both the national and the regional level. So the regions, by extension, are the arm of Ghana Service Headquarters at the regional level, overseeing the delivery of pharmaceutical services within that region and also the districts. We'll begin by taking a look at our workforce as pharmaceutical service. This table for me is not complete because in some regions, what I see is that we have data from the teaching hospitals featuring. For instance, go to Greater Accra. At post, we had about 225 pharmacists. No, it includes data from Korle Bu. So we expect that in our presentations, we'll give us the true picture of our human resource at the regional levels. But also then done, you would also realize have a yawning gap in terms of the pharmaceutical workforce, the pharmacy technicians, and also the pharmacy assistants. Putting all together, the gap is more than 2,500. And every effort should be made to ensure that this is addressed. Because if we don't have quality pharmaceutical resource at all levels of the service, then we can be sure that we are going to deliver substandard pharmaceutical levels, services at these levels. Of course, the first thing we do as pharmacists, and I want to say it again, is the management of essential medicines. And nobody should deceive you or deceive us by telling us that when it comes to managing essential medicines, that is not the role of the pharmacist, it's the role of someone else. It's not true. Medicines management remains and continue to remain key aspects of the work that we do. We'll begin procurement of medicines within the service. And once again, I must confess that this is not complete data. We are still looking forward to regions giving us updated data, which will be verified after this performance review session. But you realize that the total essential medicines procured grew from 164 million in 2022 to 424 million in 2025. And this represents 158% increment over these 4 years. This growth reflects both increased procurement volumes and values and the impact of currency depreciation on medicine price inflation. And it is important to note that this data reflects medicines reported through GILMIX at the regional medical store level and represent only a portion of the total medicines expenditure, as facilities we know also procure a lot of medicines from the private sector. All right. In terms of value, this pie chart gives us the procurement of essential medicines by value and class using the ATC classification system that was developed by WHO as far back as the 1970s. You would realize from this pie chart that as a service, the procurement of anti-infectives for systemic use or antimicrobial agents was more than 20%. Of course, if you put in terms of value, the procurement of musculoskeletal system medicine, analgesics, whatever I can think of, and add on the anti-infectives and the cardiovascular, as well as alimentary tract metabolism and blood and blood-forming organs, medicines affecting blood and blood-forming organs. Only these 1, 2, 3, 4, 5 put together constitute more than 75% of total procurement. And for that matter, it points to the fact that there is a need for us to establish strong antimicrobial stewardship programs in our hospitals. Sometimes I also find it difficult justifying why we spend so much as a service on medicines affecting musculoskeletal system, as well as medicines that affect blood and blood-forming organs in terms of hematinics. It's a bit baffling that we spend so much, and that also points to the fact that we have to strengthen our drugs and therapeutic committees. Having said that, the increasing expenditure on cardiovascular medicines, as well as medicines affecting the metabolic system, especially diabetes, also points to the rise in non-communicable diseases within our population as a country. And I'm very happy that currently the College of Pharmacy is training specialist pharmacists. And I've always said that that is where the future of pharmacy lies. Being able to support the system when it comes to management of these cardio-metabolic diseases within the service. So this chart gives us the procurement basically on antibiotics. But one of my concerns here is that you realize a huge chunk was spent on quinolones, which of course remains reserve antibiotics. For the penicillins and the other beta-lactam antimicrobials, they are access medicines. But for quinolones, they remain reserve antibiotics per WHO using the WHO aware classification. And there is a need for us to strengthen our DTCs so that whatever prescriptions of these medicines are made, prescribers should have justifiable reasons why they are prescribing it. In terms of tracer medicines availability, you realize that the national average tracer medicine availability has improved from 69.6% in 2024 to 74.9% in 2025. And 2025 still remains our best performance for the past 5 years. Eastern region leads with 93.3%, and Upper East region also made a remarkable recovery from 38% in 2022 to 89.7% in 2025. So we realize that the national average reached 74.9% or 75% in 2025, up from 69.6% in 2024. And like I said, it was the highest in the 5-year reporting period. 8 of the 16 regions scored 80%. And of course, Eastern region demonstrated the most consistent, or has demonstrated the most consistent upward trajectory from 80.1% in 2021 to 93.3% in 2025. And Eastern region should be recognized as a model pharmaceutical service within the service. Northern region oscillation between 43% and 54% for the past 5 years without a sustained recovery is a still level concern, requiring structured intervention beyond annual reviews. And I know that my colleague who is there, Ike Memory, will do his best to bring the region to speed. Let us also continue with medicine safety and quality improvement. We are all aware that there is currently a growing concern when it comes to issues of patient safety. And most issues of patient safety borders on medicines safety. We'll look at our REM indicators for 2017 to 2025 as entered in DIMS. So this data was obtained from DIMS. And you realize that our average number of medicines per encounter hasn't changed significantly. It hovers around 3 medicines per encounter, which is above the WHO recommended target of 2. All right. In terms of percentage of medicines prescribed by generic, you also realize that it's basically hovered around the same figure, although we've not gotten to 100% mark yet. Right. Medicines prescribed from EML has also shown remarkable improvement. But in this era that we are using the medical electronic record system, we expect that this should be 100%. Because medicines in our medical record electronic system, or LIBS or GIMS for now, is usually written in generic. So we are supposed to get that 100% for now. And that target is not far-fetched. We can still achieve it. All right. One key concern we are beginning to see is also after the decline in the use of injections. We have come to the realization that the use of injections is beginning to go high. And this requires urgent investigation. Of course, our drugs and therapeutic committees must treat this as immediate priority in the upcoming year. One area where we've made remarkable improvement per this data is percentage of encounters with antibiotics prescribed. Like I said, this data was picked from DIMS. And you realize that we've made a consistent improvement from 2020, post-COVID 2020, to 2025. But interestingly, data from the regions does not also seem to suggest that. Data when you go for the review meetings at the regional level, almost every region has challenges with high antibiotic prescription. So I find it difficult to reconcile the two data, that in DIMS and that also at the regional level. And I think this requires to be further investigated. Reporting medication errors by pharmacists is being a very big challenge. Not all regions are able to do this. And for this very performance review meeting, we'll sit down and have a look at what the regions have been able to do to improve the reporting of medication across. We would continue to medicines financing. I think we all know that one of the key things we do as pharmacists is ensuring the prudent management of our drug revolving fund. And that explains why we are mandatory signatories to the revolving trust fund. The revolving trust fund remains the linchpin of our essential medicines concept, and every effort should be put in place to ensure that our revolving trust fund are prudently managed. Because without sufficient funds, we can't have adequate stocks of essential medicines in our healthcare institutions. And that will, of course, finally negatively impact on our ability to deliver or to attain our UHC target as pharmaceutical services. This graph we have here gives a pictorial view of management of net worth in our regional medical stores across the 11 regions that have regional medical stores. You will realize that all regions have shown some improvement in their net worth, or showed improvement in net worth from 2024 to 2025. And for me, it indicates a positive trend in the revolving trust fund financial health across the country. You realize Ashanti region records the highest net worth in 2025, figure around 80 million, followed by Eastern region and Greater Accra, which were around 75 million. Bono East, thank God for the ingenuity, also entered into the race, I think in 2024, 2025, and the net worth was around 50 million. But they are competing seriously with some regions and not have been a system for a while. There is a worrying trend we've realized in relation to managing the revolving trust fund. You would realize that nationally, our total debtors represent 49% of our net worth. You also realize that, with the exception of Greater Accra and Eastern regions, all regions, Ashanti, Central, Northern, Upper East, Central, Upper West region, show total debtors exceeding the net worth. And this signals a risk to our revolving trust fund liquidity and requires targeted debt recovery efforts to address this. Another trend we've also realized is that hospitals, which accounted for 36% of our debtor schedule, was far less in terms of the schedule. But health centers were the highest. Health centers accounted for 59% of our total debtor schedule as compared to our hospitals. And there are several reasons for that. The reason being that at the health center and the chief compound level, we don't have competent pharmaceutical staff to manage a revolving trust fund and medicines at that level. And we also see this as a threat to the government's free primary healthcare policy initiative. Because if medicines are not properly managed at the lower level, the chief compound and the health center level, it then implies that as a country, that policy that we are trying to roll out is going to have significant challenges. Let us also take us through some operational research we did as pharmaceutical service involving headquarters and the regions working in collaboration. Along the line, we asked all regions to give us data, to submit data on the operations of the herbal medical services in their facilities, on their regions. The data we obtained from the regions was interesting. In the first place, we saw that herbal clinics operate in 13 out of 16 regions. We also realized that most of the medicines were sourced from the Center for Plant Medical Research at Mampong, Ekrapim. The formulations used were basically mixtures and syrups. Only a few had capsules and tablets as their formulation. One of the things that we need to do based on this research we conducted, the pharmaceutical survey, we have to extend our mandate to cover herbal medical products within our facilities. And one of the things we recommended to the service is that the service should develop a comprehensive regulatory framework for herbal medicine practice in Ghana to ensure successful integration of herbal medicine into orthodox medicine, and of course, also including an essential herbal medicines list. I'm told the FDA is now developing an essential herbal medicines list. We are waiting for them to develop that so that we can also incorporate it into our essential medicines list. We also realize that some regions, especially those up north, were denied such services. But the WHO has made it categorically clear that herbal medical practice should be effectively integrated into orthodox medical services so that people who want to seek assistance from our revered herbal medical practitioners can do so without any risk to them. In terms of achievements, pharmaceutical service at all levels, it being headquarters, it being everything, has done so much. But I want to limit ourselves to headquarters for now. The capacity, the human resource capacity in headquarters has been built. And like during the introduction, we heard that we have 6 pharmacists now at headquarters with support staff, about 7. The office has also been adequately resourced in terms of office equipment and whatever you can think of. An official vehicle has also been allocated to the office to strengthen monitoring and supervision. Some colleagues in the office took an active part in capacity building for health staff on oxygen management to enhance quality care delivery at the facility level. And others also successfully took part in regional workshops to institutionalize antimicrobial stewardship in selected health facilities to promote rational use of antimicrobials in these facilities. In terms of innovation, the office has been able to digitalize the pharmaceutical services annual reporting format, which most of us are currently using, or most of us, which we are all using to report on pharmaceutical services for 2025 and expected to use. Of course, we are also in the process of developing a medication therapy management tool, MTN2. And in the course of time, our IT expert will speak to that. We are also in the process of developing Ghana Drug Interaction and Polypharmacy checklist. We all know polypharmacy is one of the key challenges that accounts for a large proportion of reductions of medicines submitted to NHIs. So as a service, we are in the process of developing a checklist so that once medicines are prescribed, at least you can pass it through to know whether they are practicing polypharmacy or not before dispensing. So way forward, luckily for us, pharmaceutical services has been captured under Pillar 2, Intervention 7 in our Ghana Health Service strategic plan from 2026 to 2030. And for me, that is a noble achievement. There are about 9 areas we have incorporated into our strategic plan as a service. And what we intend doing as pharmaceutical service is to enhance medication management. So if you open the strategic plan to Pillar 2, Intervention 7, you would see enhancing medication management, and that borders of pharmaceutical service. And there are 9 key things we intend doing, and that cuts across headquarters to the regions, districts, and sub-districts. The first is standardizing and institutionalizing what pharmacy practices across Ghana Health Service facilities. And that also explains why we've roped in a number of seasoned senior specialists as regional heads to support in this direction. The second is to improve medication safety and quality management system at all levels of the service. The third being institutionalized antimicrobial stewardship and surveillance programs at the facility level. The fourth is to institutionalize health technology assessment for evidence-based pharmaceutical decision-making within the service. The fifth is to implement pharmaceutical traceability strategies to track, trace, and detect substandard and falsified medicines. C, promote appropriate use of medicines and other health technologies among prescribers and patients. The seventh, to strengthen drug monitoring to detect, assess, and prevent adverse effects, medication errors, and drug-related problems. The eighth is to provide reliable, and drug information services is to provide reliable, balanced, and health-related information to the public and health professionals. And finally, develop our human resource capacity in order to meet these service delivery demands. On that note, I want to thank all of us for supporting pharmaceutical services. I want to thank the Director General of Ghana Health Service. He's been so supportive. The Deputy Director General. I want to thank all divisional directors at headquarters and also all regional directors. I want to thank all former chief pharmacists and directors of pharmaceutical services at headquarters. I want to thank all our revered chief pharmacists, all our heads of district hospitals, and our pharmacy technicians that continue to support us at all levels. May God bless us all, even as we continue together to advance pharmaceutical services for every Ghanaian in Ghana. Thank you very much.
Thank you. Thank you. Thank you, Director. That was an extensive presentation. Okay, so now headquarters has presented to you based on the data we have and the plans we have and what we've been able to do in the past year. So at this point, we will open the floor for questions, suggestions, anything anybody wants to contribute to. The floor is now open. Hello, managers, pharmacy managers. Please, the floor is
Hello.
open. Yes, hello.
Yeah, Auntie Edna, thank you. I want to thank Director Ochre for a very brilliant presentation, very informative, and showing us leadership. My concern is with the huge indebtedness of facilities toward the regional medical stores. The analysis he projected where health centers higher than even hospitals. And these health centers, we hardly have pharmacists and also the pharmacy workforce.
Up a little bit.
Especially, hello, can you hear me?
We can hear you, but speak up a little bit more. Thank you.
Okay, is it better? Hello?
Yes, please.
Hello?
Please let me hear. Yes.
Yes. Yes. So
Yes, we can hear you.
lower facility, yes, thank you. At the lowest facility, at the CHIPS compound and the health centers, where pharmaceutical workforce is really lacking, and where these huge debts are coming from, what can be the strategy if director can help us? Because reaching out there, you go there and you have just the PA and health, community health nurses there, and managing of medication and pharmaceuticals at that level has always been a challenge. Even getting data and even people to manage those things at the downstream, the workforce challenge has always come up. And what is the best way going forward to address this huge indebtedness at the health center and the CHIPS level? Thank you.
Thank you, Chief Felix. Well noted. Please, Director will respond to it. But before that, Dr. Emmanuel Kowiafe, please, the floor is open for you to make your contribution or ask your question, and then Director will respond.
Okay, so good morning, Director. Good morning, my distinguished chiefs, and then other senior managers on the platform. So please, my first question, okay, the first one is it's a compliment. It's a very great presentation by Director, and I mean, we are very much convinced that everything is on course, of course, to improve on pharmaceutical care. I mean, building upon, the predecessors. My first question is on how do we improve on direct reporting on the DIMS? If we look at the various parameters and data sets on the DIMS, for me, my facility, though I'm with CHAC, there are some aspects I report, and I have, access to the data sets. You realize that there are some key aspects of pharmaceutical care that is not on the DIMS. For now, you look at doing the rational use of medicine survey, which, if you want to even narrow down what we particularly report on directly on the DIMS, is the prescriber indicator survey, which is not actually even a direct work of we as pharmacists. We assess prescriptions from prescribers. Is there a way we are looking at improving on our reporting, such as, say, if you look at the nursing aspect, even OPD attendances, midwives, they do recording, monthly recording on even deliveries, etc. Are we looking at a system of reporting, say, the number of prescriptions we serve, OPD, inpatients, monthly on the system, etc.? And then are we looking at a way to input directly some of these fine data sets from the facilities that pertain to? And then my second aspect is on from director's report. Of course, we obviously have there's a gap in the staffing. Is there a strategy, especially with the announcement from the Ministry of Health about the way they want to recruit now? I wanted to find out if there is a strategy, how to generate these, what they are referring to as verified vacancies, so we can be assured that, yes, our districts have generated enough vacancies for us to fill in the gaps for both pharmacists and then our pharmacy technicians. Thank you very much.
Thank you, Chairman Oriafi. Very well noted. Emmanuel, please, I see your hand up, but I would like Director to respond to these two questions and then we will take your questions. Gideon, I also see your hand up, so we will come to you. Thank you.
All right. So let me thank you so much for the questions you asked. And good morning, Chairman. It's nice listening to your voice this morning. That is the reason why we are here this morning. Okay? We are here to identify the strategies to address all these concerns that we've raised. It's interesting, Chief Ellis was asking questions about medicines management, challenges of medicine management at the sub-basin level. I expect that as the regional chief for Upper West, he should be telling us all the strategies to address it. Okay, so me as the director at headquarters, what I did or I sought to do was to put together all data and bring it to the fore for us to discuss. After you've also given us the most up-to-date data, because for now, the data we have at the headquarters level is not up to date. So, colleagues, we have noted all your questions, but going forward in our presentations and everything, we should also be looking for solutions and strategies to address it. That is the essence of the review meeting that we are doing this morning. So we noted it down, and as we walk us through your presentations, we try to collect all the thoughts that you have as how to address these things, put it together, and then see the way forward. Thank you very much.
Thank you, Director. We will move on to the next two, beginning with Emmanuel.
All right, thank you very much, Director and team, for the presentation. My first one will be on the tracer drug availability. I don't know if there has been a newly published list of tracer drug that we are using, because you mentioned that Eastern region was able to do about 90% plus of availability of tracer medicine. But considering the list that is being used, I would want to know if those medicines that we are currently not using are still part of the base, the denominator in doing these calculations. And then my second one will be, I think, strategic plan for 2020, and with the 9 areas, thinking about logistics management as pharmacists. Recently was about Greater Accra, where
Please, can we still hear Emmanuel, or it's just us that can hear?
No, I think he's off. Yeah.
Okay. Okay, so
His line is off.
we'll wait for him to come back with the second one. I think it had to do with logistics management, but we'll wait for him to come back with the full question. Okay, so please, Gideon, the floor is yours. Gideon Affo.
Good afternoon.
Good afternoon.
Thank you for the presentation. My first question is also on the tracer medicine availability, and it's similar to what the other presenter asked. I was asking how a review of the old list that we have. And then the second question is on pharmaceutical financing. Very often we hear the word drug related activities when it comes to spending on pharmaceuticals or by pharmacy. Now, this is a broad term that is being used, but it is not well defined. Is it possible that the pharmaceutical sector can define some key areas that you have to look for when it comes to drug-related activity, when it comes to the financing of the activities? Because what I've realized is that some of the directors, some of the med soups are hiding behind drug activity, other things. So if we are able to define what drug-related activities are, then we'll be able to protect it when it falls outside those drug-related activities. Thank you.
Thank you, Gideon. Well noted. Emmanuel is back. Emmanuel, we heard your first parts, but we couldn't hear the second. So please.
Yes, thank you very much. Sorry about, I think, internet issues. Yes, my second question had to do with issues of supply chain and medicine management. Director, on his last slide, I think, was talking about the strategic plan 2026-2030, where we have 9 blocks for pharmacy. And I didn't see any of the blocks talking about supply chain where pharmacists will be leading that area, because recently we had an issue of a letter going around indicating that hospital administrators are supposed to take charge of pharmacy stores, which I think created a whole lot of back and forth, a whole lot of letters going back and forth. So I would want to know what strategy we have as a department or as a directorate to look at supply chain in the scheme of activities. Thank you.
Thank you, Emmanuel. Your questions are well noted. There's a question in the chat box I'll be reading pretty soon. And so I want to remind us all that if you are not able to ask, maybe due to network challenges or anything like that, you can also type it in the messages and then we will read it. So the question in the chat says that, good day, Director and Police. Good presentation, Director. Please, I hope the presentation slides will be shared because they are vital info we need. Thanks. Okay, I want to assure you that yes, we will share the presentation slides with the chief pharmacist. So since we don't have everybody's contacts, please contact the chiefs and then they will share with you the presentation after we are done tomorrow. I hope you know that this review is taking 2 days. We're doing today and tomorrow because we will not take the whole day. We will close after 2. So please take note. We will share the slides, but contact the chief pharmacist for the slides. Thank you. Any more? Okay. So Chief Note, please be getting ready to make your presentation because we will be moving on to the regional presentations for the first section. Okay. Well, in response, please, is somebody asking anything?
Okay, now saying is well noted.
Hello. Yeah.
Okay, please go ahead.
Hello, my hand is up.
Yeah, Bayo, go ahead.
Yeah. Good afternoon, colleagues and senior colleagues. My own is a bit of a contribution. With respect to the medicines management at the lower level, especially the health centers, where there are issues, I want to bring in some suggestion. I detected same, and I spoke with the regional director, and then we engaged all the district directors. I know, and we all know, that the loose management of medicines at this lower level, some people are benefiting from it. So if it is to be tackled, you have to tackle it holistically with the support of the district directors. So what I propose to them is this. In every district, if there is even one technician there, we will use that one technician, train him, and then add him additional responsibilities or reassign him to the district health directorate, so that that officer will support in the logistics management there. We are not just going to tell him to go and do it. We will train him and let him have a template, a format that he will use, collect, let's say, stock taking, and then input the data. He'll be able to come out with calculations that the district director will understand. I had a presentation with them on this aspect. Thankfully, all the district director welcomed the idea. So they have decided that they will give me time where they invite all health centers in charges and those managing the medicines. And I'll make presentations to them on medicines management and how beneficial it will be if the medicines are well managed. I'm yet to start that presentations in the districts, but it has been a welcome idea by the regional director. All management, what they tell me is what they really mean. It means that we could possibly make progress in this direction. I just wanted to share what we are doing with respect to that aspect in terms of the lower level medicine management. Thank you very much.
Thank you, Doc. We are very grateful for that suggestion, and we are happy that it has been welcomed. The idea has been welcomed. And we'll be expecting colleagues to come up with more of such suggestions of how to manage the issues that we have identified needs to be addressed. On that note, I want to say that the questions we have taken note of, but they will not be answered right now. As we go through the presentations, we expect more suggestions. And then at the end of the day, at the end of second day, we will all brainstorm on the way forward, and some of these things will be addressed. Thank you. So on that note, we will now move on to the regional presentations, beginning with Oti region. And Farmer Vladi will be projecting from here. All the presentations will be projecting from here. So we'll project and then you will go ahead. Oh, you project.
Hello.
Hello, Farmer Vladi, can you hear?
Hello.
Yeah, please go ahead. Nee, you can go ahead.
All right. Okay. Thank you very much. On to all of us, and I bring warm regards from the team in OT. I'd like to acknowledge that my pharmacy managers from OT regional online. Now, thank them very much for support. All this. My name is Vlad, and the active close to 799,000 people with 9 administrative districts and then 49 sub-districts. We have a regional hospital. We have one district hospital that has taken up the role to act as a regional hospital, but formally it's still a district hospital. It's not yet recognized as a regional hospital. We have 4 Ghana Health Service health hospitals that act as district hospitals in 4 districts. So 5 of our districts technically do not have district hospitals. In all, we have 10 private hospitals and then polyclinics in OT, and then 4 CHAC facilities that are also spread in the region. There are 40 health centers in all. 15 of them are practicing the networks of practice, and they are model health centers. We have 200 CHIPS compounds, retail pharmacies, about 21 of them, and then the OTCMs, which was validated this morning. The number for this morning. So that will change the figure a bit for us. So in all, we have 507 health facilities in OT region. At the beginning of 2025, we had some specific challenges peculiar to our region. The first one, which was already hit on by Director, was the inadequate skilled workforce to deliver quality pharmaceutical service. And when we get down to the numbers, we'll get to see that we actually don't have enough pharmacists, enough pharmacy technicians to help do the job and do it well. The Food and Drugs Authority, through the course of 2024, conducted an inspection of our storage facilities and then our distribution practices. And there were huge challenges across various districts, across various levels, hospitals, health centers. And it's now Director. And it was one key issue that we had to deal with 25. We also had low reporting of adverse drug reactions from the facilities, especially the lower level facilities, our health centers, our CHIPS. The reporting rate was quite low for them. And then high antibiotic prescription rate. If any of us followed the news, we were on the news recently, infamously for high typhoid cases in our region. And in fact, for 2024, the prescription rate of antibiotics for our region was around 48%. So in essence, every 10 people who come, almost 5 of them go home with antibiotics. And that's the situation we had for our region. There was poor pharmaceutical data quality in DIMS 2, especially with the pharmacy related data. Reporting rate for some of the indicators were as low as 44% for 2024. And there were some errors in terms of the data. I'll go through, we'll see one key one that came out during the performance review. There was also a high NHIS claims rejection rate, and I'll be presenting on the finances. We'll see that a huge chunk of our revenue comes from health insurance. So if we are losing that much due to claims, then it creates a big problem for us. In fact, the claims rejection rate was highest for the lower level facilities, especially the health centers and the CHIPS. And I think the discussions we've had so far tells us that the pharmacists, pharmacy technicians are needed at these levels to be able to curb this negative trend. Then there was a low chemist utilization rate for us as a region. Our utilization rate for 2024 was around 31%, very, very, very low, not what we expected. So we set out as a region with some priorities. First was to deal with the number of workforce that we had. In fact, we worked with a lot of vim to try and get more pharmacists in. Unfortunately, things didn't go as planned. We had one pharmacist joining us in one of the districts, which was quite good for us. We had one technician who also expressed interest in joining us. He's currently with us, working in one of the health centers. So that was a positive thing for us. And it's something that we are continuing to do with the hope that we'll be able to get more pharmacists and more technicians into our region. Second was that we needed to improve on the capacity and the skills of the pharmacists and the technicians that we had in the region. So we set out to support pharmacists and technicians to be able to go and upgrade themselves. Currently, we've been able to have 4 pharmacists who are at the colleges of pharmacy. We have 2 technicians who through us got steadily. There are 3 dispensing assistants who we are also supporting to pursue pharmacy technician courses. Hopefully this year, next year, the dispensing technicians should be done and they'll be back with more knowledge and more skills to help improve pharmaceutical service in the region. We sought out to train our health staff on good storage and distribution practices to address the gaps that were identified by the Food and Drugs Authority. We sought out to train health staff again on pharmacovigilance to be able to improve the reporting rate of adverse drug reactions. We had to make noise, quote unquote, to try and get attention on the typhoid cases that we were having. In fact, it's not just about health. There were other environmental issues. And so the regional minister came on board, and then together with him and then some journalists, it became a big issue. And we had Director General sending a team from Accra to help us develop a response strategy to be able to cases in our region. We also set out to train heads of pharmacies on data entry and how to take ownership of the pharmaceutical related data in DIMS so that we would improve on the reporting rates, improve on the correctness of the data that we have in the system. And then to meet stakeholders to resolve the high NHIS claims rejection rate. The stakeholders specifically were pharmacists, medical superintendents, district directors, the health insurance team in the region, accountants, and then claim officers. And then finally, to train pharmacists and store managers on GeoMix utilization to be able to improve our GeoMix utilization rate. So with the workforce for OT region, like I mentioned, we had 1 pharmacist joining us. She's not mechanized. She's being paid with IGF. And it's our hope that if the portal is opened, we'll be able to draw her in and then keep her in the region for good. For our mechanized staff, we currently have 2 specialist pharmacists in the region, and then other cadre of pharmacists, pharmacy technicians are 4 on GOG payroll at 28. So total mechanized, we're looking at 50, but there's a huge gap in total of around 164 of such pharmaceutical cadre staff. Our pharmacists who are not mechanized yet, who are being paid with IGF, are 4, and all these 4 are working in CHAC facilities. It's been a very, very tough road for them because the IGF pay naturally is not too good. And I would like to commend them for still holding on all these years, working with us with the hope that we'll be able to get them in. And we are seriously considering that when the portal opens, we'll be able to get them also employed on GOG so that we get to keep them in the region. We don't lose them. There are 2 pharmacy technicians who are also not mechanized, who are being paid with IGF. And then 49 dispensing assistants who are also not mechanized and are being paid with IGF. So in total, we have 55 pharmaceutical staff who are not mechanized and are being paid with IGF. In summary, 109 in terms of the gap that we need to add to our numbers to be able to get the right staff that we need to provide pharmaceutical service in the region. For our general clinical services, for 2024 and then 2025, 2025 had a marginal increase, wasn't too much, 662,000 averagely for 2024, 698,000 OPD visits for 2025. The difference wasn't too much. In terms of OPD visit per capita, it was really around the same figure. The OPD visits per insured clients was 522, which tells us that close to 80% plus, almost getting to 90% of our patients are health insurance patients. The patients who came to the OPD largely came in terms of conditions that brought them, the top 10. Top 3 of them was uncomplicated malaria, rheumatism and arthritis, and then upper respiratory tract infections. In terms of admissions, we had 32,000 roughly in 2024, 36,000 roughly in 2025. And the main drivers of our admissions were severe malaria, gastroenteritis, and then hypertension. And I think the gastroenteritis emphasized the key challenge we were having with typhoid in the region. That was mainly driving the admissions for IPD together with malaria. And it highlights why we are using ciprofloxacin so much in the region. The major surgeries we had were 2,284 in 2024, 2,270. They were basically the same, around the same figure. And the main driver of our surgeries were cesarean sections and then hernia repairs. And then we had 522 deaths in 2024, as against 572 deaths in 2025. And the main driver of our deaths were lower respiratory tract infection and then hypertension diseases. I think the director mentioned that we should begin to look out for these conditions, which seems to be rising. And as pharmacists play a key role in helping our patients get well educated on them, adhering to therapy, and then properly managing them as such. Pharmaceutical care for OT. 2024, we only had data from 2 facilities. 2025, through the performance review meeting to help iron out the challenges that facilities were getting, trying to make sense of the data. So in 2025, we had 7 facilities reporting. So the figures in 2025 is more reflective of us as a region than 2024. So in 2025, averagely per month, we are serving around 16,019 prescriptions, making about 534 prescriptions per day. Health insurance cases forming close to 145,492. Like I said, is the main driver of our patients and then our revenue. And then in terms of revenue, 6.3 million for insured clients, and then 4.6 million for our cash patients. Facilities was 472, and in 2025 we significantly improved to 896, and I commend my pharmacy managers for the great efforts they put into this indicator. Medical ward activities, we didn't have much to report on in 2024. In 2025, we were able to get some data from the facilities. 2025, the drug therapy problems resolved was 15.4% from what was submitted by the facilities. Discharge counseling performed was 28%. And then the emergency medicines accessibility on the ward, we used the peer review that we did in 2025 as a proxy. There's an indicator in there. So averagely, that was around 94% as a region. And the medication errors, there were 393 medication errors that were reported for 2025, which was also an improvement over 2024. 2024 was far less than we had in 2025. And the chunk of them were mainly prescription errors. There were a few dispensing errors, a few administration errors. The administration errors specifically being doses that were not administered and doses that were not following the time that had been prescribed. All the 393 medication errors did not cause any harm. No patient died as a result of them. The adverse drug reactions we had as a region significantly was higher, 406 for 2025, and the greater portion of them were from the SMC exercise by the National Malaria Elimination Program. And these were reactions to sulfadoxine, pyrimethamine, and amodiaquine that were given to the children. And a chunk of these reports came from the health centers and then the CHIPS, which was very, very, very good for us because it meant that the efforts we had put in to train them was actually yielding results. The other reactions we had were for metformin, ciprofloxacin, nifedipine, antiretrovirals, and then diclofenac. But a chunk of them was from the sulfadoxine, pyrimethamine, and amodiaquine. The outcomes of the adverse drug reactions: 401 did not require hospitalization. 5 of them had to be admitted at the ward, and these were children from the SMC program done by the NEDP. All of them recovered, all of them were discharged, and all of them are fine as at the time of reporting. So 406 of them recovered fully. Our rational use of medicine survey indicators. 2024-2025, the average number of drugs per prescription was still largely around the same figure. As a target, we are looking to do at least 3 or less. We are still marginally higher, and it's something that's, looking at it, we can still do better and bring it down to 3 or less. Percentage of medicines prescribed by generic name. As you can see, you cannot have 106.4%. And this is what highlights the challenges we were having with data accuracy for some of the entries that were done. And so in 2024, this was an anomaly that came up. We tried to get it corrected, but it wasn't corrected in time. And then it finally came out in the annual review, unfortunately. 2025, the percentage of medicines prescribed by generic name is 99.66%. We are just some few decimal points away from 100%. Percentage of prescriptions with written antibiotics, 48.6% in 2024. There's been a marked improvement in 2025 to 26.56%. And I commend the team at Dambai Hospital Health Center, if I would call them so, if they allow, who put in so much effort to help bring down this figure, because a lot of the typhoid cases were coming from that side, and they were driving a lot of the antibiotic prescriptions for us as a region. Percentage of prescriptions with injections is still good, 8.61%. 2025, it came down to 7.4%, and it's still within the recommended range. We hope that it goes lower over time. Percentage of medicines from the essential medicines list, 98% averagely for 2024 and 2025. We still have room for improvement to be able to hit the recommended target of 100%. The other indicators, unfortunately, we did not have data to present on them. Average OPD consulting time, dispensing time, percentage of prescribed drugs that were dispensed, percentage of drugs adequately labeled, percentage of patients with knowledge of correct dosage. I didn't get data from my facilities in that area, and we'll work on it going forward. And pharmaceutical supply chain management and financing. So OT is a new region, a baby region. We don't have a regional medical store in the sense of what Greater Accra has or Eastern Region has, but we have created our own baby stores, which we call TRMS. And that store has been very, very, very instrumental in the distribution of the NOP medicines and logistics that have come to us. So we've tried to use that to put together some figures for presentation. So in all 2024, we're able to send to the facilities medicines valued at 698,000 thereabouts. 2025, we pushed a lot more to the facilities, around 3,668,000. In terms of payments and receipts, 2024, we got nothing back from the facilities. 2025, we were only able to collect 30,017. That was just less than 1% of a debt recovery rate. So in 2026, first quarter, we actually changed the model. We're a bit more aggressive. So we met, and then there was a more aggressive push to do debt recovery. So we visited facilities, put pressure on the accountants and then the pharmacists, and we're able to collect around 400,000 thereabout of first quarter. That was around 10% debt recovery rate. And it's our hope that we'll get further going into the year to at least be able to collect more than half of what we have sitting with the facilities. And the challenge here largely has also been the lower level facilities. We are not getting the monies back from them. And it still highlights the challenges we have with medication management at the lower level because we don't have the key pharmaceutical cadre there to help with that effort. Tracer medicines availability, we move side by side with Volta. So 2024, roughly 64%, 2025, it improved to 71%, which was a good sign. So facilities that owe us from what OT regional medical them, the hospitals form about of the bulk of our debt. And the health centers, together with the CHIPS, are taking almost about 70% of the debt. And that is a challenge that we have, being able to get these monies from them, especially when the management of these medicines is not going as you expect it to go. And then they are also losing a lot of claims, far more than the hospitals are losing. We don't have much to report on the analysis of pharmaceuticals by class and value. So that section is blank for us. Yet nothing to report on the results yet. It's still being compiled. Nothing to report on the working capital yet. We need some data from the regional supplier money on the stock values take, which wasn't available. So Deputy Director of Finance couldn't supply that for the report. In summary, what we were able to do in 2025, number one was we liaised with the FDA to train health staff at the sub-district level on pharmacovigilance. So we trained quite a number of health staff from different cadres, physician assistants, medical doctors, pharmacy technicians, pharmacists, nurses, midwives, and it actually helped improve our adverse drug reaction reports. 2024, we did around 132. 2025, we more than doubled that, almost tripled that. For the efforts we got a computer from the Food and Drugs Authority in recognition of our efforts in medication safety monitoring. Number two, we liaised with the FDA to train pharmacists, internal auditors, and supply officers on good storage and distribution practices. And it was an eye-opener because one thing we realized was that there was a knowledge gap, especially with some of the supply officers and then some of the key people we needed to help push this forward, especially the internal auditors. And there were some very good recommendations that came out for us to follow up in 2026. We liaised with S4D to train pharmacists and supply officers on GILMIS utilization. Now, in 2024 improved to 68% in 2025. We prepared and submitted to the Regional Director of Health Services a situational report on medicine stores and supplies in OT, and that document became the main driver for the stakeholder engagements. So far, we've had engagements with some key pharmaceutical companies, with some key political figures, the traditional council, and then others who could help us be able to establish our stores. Pharmacy staff supported to take advantage of study leave to upgrade their knowledge. Like I said, 3 pharmacists had it in 2025, 1 had it in 2024. By 2025, we were able to get 3 pharmacists and then 2 technicians. Training and integration of Drugs and Therapeutics Committee at Dambai Health Center. This was the first time they were having a Drugs and Therapeutics Committee. Dambai Health Center has a medical officer, has a pharmacist, a full complement of a BMC. So there was a strong push by the pharmacists there, and together with myself and the Deputy Director of Clinical Care, we moved in to train them and then integrate their Drugs and Therapeutics Committee. And it has really been useful in driving down the antibiotic prescription rate and improving medication management at that facility. In conclusion, we've made some good progress, particularly with pharmacovigilance and then gas especially. However, we still have gaps to address when it comes to clinical activities. There's still room for improvement. We'll continue with our advocacy to improve on the strength of the pharmacians in the region. Our recommendations and then next steps. One, advocacy would continue. There's been a lot of advocacy being done at the top. Director himself, I think Gospa too is doing the same, and we would also lend our effort to be able to achieve this for the greater good of all pharmacists. Certainly for pharmacy cadre to upgrade their knowledge and skills. We realize that in activities that we're not getting in the data of regional director of health services and then committee to stakeholders and partners to our stores. We work with pharmacy managers to harmonize annual performance objectives. We actually did that, which was a guide for us to use to fill the PMS, the online system that came out recently. Next steps, we plan to implement antibiotic stewardship programs at hospitals in OT. Fortunately, we have some strong team in Volta who would help us. I saw Dr. Sefa online. He's one strong pillar in that area, and we plan to also follow on him to support us to develop an antibiotic stewardship program in OT region. We will refresher trainings again on the great to have Dr. Anna contribution practices at health facilities. So this came up during the deputy director, myself, deputy director of finance, will be working on this to check on the good storage practices at the health facilities. And then we'll continue to organize the quarterly performance review meetings for heads of pharmacy. We want to rope in the health centers, some of the pharmacy technicians there, so that we'll be able to spread the good news better. So this is what we have from OT region. Thank you very much.
Thank you very much for that excellent presentation, Kwame Note. Thank you. Yeah, that was really good. The only thing is, I think you went beyond the allotted time, but I didn't remind you, so I will forgive you for that. But for the upcoming presentations, please note you have 20 minutes for the presentations. 20 minutes. Okay, without much ado, we are going to the next presentation from Savannah region. After that, after Savannah, then we will have questions and answers and take a little break, and then we will continue. So Savannah. Okay, please go ahead and project.
Hello. Good afternoon, everyone.
Good afternoon.
My name is Mark Bayo Chengbe, Acting Regional Chief Pharmacist, Savannah Region. Some of my colleague pharmacy managers So the president yes region with total land mass of 10 square kilometers. The population is highly sparse in the region.
Hello,
A
Mark.
very large region with
Mark,
hello.
please, we can't.
Can you hear me?
Yeah, we can hear you, but we can't see your presentation.
Oh, I thought you were projecting it from your end. That's what I heard.
Okay, all right. Just give us
Correct me if I'm wrong.
yeah, give us a minute to project it.
Good. Good.
Yeah, Mark, go ahead.
Okay. Like I said, the Savannah region remains the largest region in the country with a landmass of 34,790 square kilometers. The population in the region is sparse. The year 2025 population is 739,914. So you have a large region with this population. So what it means is that the districts are far apart and human settlements are equally far apart. It has huge implications on getting access to them and then giving them quality care. The region has 7 administrative districts. The number of sub-districts are 40. The region currently does not have a regional hospital. It is the Bole District Hospital that is acting as the regional hospital. The metropolitan, municipal, and district hospitals, we have 5 district hospitals. So 2 of those are the North Gonja and Northeast Gonja. The quasi-government hospitals or polyclinics are 4. Model health centers are 14. Non-NOP health centers are 19 for the year 2025. The CHIPS compounds are 111. Retail pharmacies are 35. And OTCM sellers is 68. So we have a total number of health facilities being 258. Now, in terms of governance and leadership, the region's specific challenges. The beginning of the year, the region does not have a regional medical store. So lack of regional medical store is one of our specific challenges. There is erratic and inadequate supply of essential medicines. There's erratic and inadequate supply of program medicines. There's low staff strength, as it is indicated by my other colleague who presented. There's low tracer medicines availability at the Northern Regional Medical Store. And so, but that is where we depend on. So when they don't do well, it affects us. There's high antibiotic usage in the region. There is lack of district hospitals in the 2 districts. I mentioned North Gonja and Northeast Gonja. The high indebtedness of the DHs to the Northern Regional Medical Stores. And there's also high indebtedness of the NOP facilities to the Savannah Regional Health Directories. Now, the regional priorities were these. Number 1, to lobby for the establishment of a regional medical store for more pharmaceutical personnel to be posted to the region and establish active drugs and therapeutics committee at all districts and polyclinics, district hospitals and polyclinics, to monitor the rational use of medicines through quarterly RUM surveys and conduct baseline surveys on antibiotics usage and advise the region accordingly. In terms of staff in the region, positions of pharmacy staff, then pharmaceutical staff complement the mechanized one. The region has one specialist pharmacist, but under normal circumstances, looking at the facilities we have, we needed 7, so there's a gap of 6. The pharmacists in the region are 9, pharmacy technicians are 30, dispensing assistants, non-mechanized, and then total mechanized staff are 40. So there's a gap of 80 on the mechanized staff. Pharmaceutical staff complement this aspect. We have dispensing assistants in the region, the MCAs. They are 40. We also have 6 pharmacy technicians that are on contract basis, casual workers. So there are a total of 46. So in summary, the pharmaceutical staff complement the mechanized and non-mechanized one. The number required is 126. Number at post is 86. The gap is 40. So we are moving to the key clinical service areas. That of 2024-2025, the total number of OPD visits 2024 is 500,065. 2025, there was a marginal increase from 500,000 to 515,000 plus. The OPD visit per capita is 0.7 for 2024, the same 0.7 for 2025. The OPD visits per insured clients saw a marginal increase from 386,000 to 389,000. Then number of admissions for 2024 is 51,789. Then that of 2025 saw an increase to 55,852. Total number of infant admissions was 5,049 for 2024 and 5,456 for 2025. Total number of under 5 admissions also from 12,000 plus to 13,000 plus. There has been a trend, an increment in OPD attendance, and in that order. The major surgeries in 2024 was 152. There was this is because Bole Hospital is Operation Hernia every year, but the year under review 2025, the conflict in the area affected a lot of things, so the Operation Hernia could not come on. So this reductions, slight reduction in the major surgeries. Total number of patient deaths, we lost unfortunately 579 for 2024 and unfortunately 562. Death per admission get this together 24. We had 250,032. 2025 is 312,540. Average percent per day is 8,344. Then that of 2025 moves, there's an increment there, 10,418. Insured client number 4,755. And marginal increase to 4,809,500. 489,000, sorry, 500. Insured clients revenue 9 million plus for 2024 and 12 million plus for 2025. Non-insured, that's out of pocket. We had 25,003 and then 25,772. These are the numbers. In terms of revenue, it generated, it was 1 million for 2024 and 1.1 million for 2025. In terms of interventions we made, 60 interventions for the fall. And 2025, we made 2,050 interventions. Clinical ward activities, this happened in the Bole District Hospital, Central Gonja District Hospital, and Bamboy Polyclinic. They gave me data on this. Completed pharmaceutical care plans, 36.1 for 2024 and 37.8 2025. Drug therapy problems resolved was 100% for both years. Discharge counseling, we're able to do 26.53% for 2024, and it saw a marginal increase to 28.2 for 2025. Emergency medicines accessibility on wards, 100% for both years. The type of medication errors, now the classification, prescribing errors, tops, 1,840, constituting 89% of all the errors. So this is problematic, but it's also because it's the pharmacy unit that is recording these errors. So you see that the dispensing errors constitute 2.93%. That is the least. Administration errors were 7.32%. Outcome of these errors, fortunately, there was no harm on any of these clients that these errors were detected. So that is a good thing to us. Sources of ADRs we recorded. In total, we recorded 83 ADRs, and these were reported to FDA. The anti-infectives were among the most, 60 out of the 83. That constituted 72.3%. That explains to us that our usage of anti-infectives are high and they are causing troubles for us. Outcomes of these ADRs, all of them recovered. There was no harm on any of them. RVM indicators. The average number of medicines prescribed was 3 for 2024 and 3.2 for 2025. It's a worrying trend. WHO says 2. Ghana says standards for 3. We were on the 3, and unfortunately, for the year 2025, we moved to 3.2. So it's something we will look at. Percentage of medicines prescribed by generic names, like Director said, with these technologies and softwares, we should have been recording 100%, but unfortunately, this is still what is happening. For 2025, 98.64. Percentage of prescriptions with written antibiotics, 44.39 for 2024 and 42. It saw a marginal decrease. It is good, but we can still do better. The standard says 20. Injections, we are doing well there, 11.37, even though there has been an increase from 2024 to 2025. On essential medicines, less 100%. Then average OPD consulting time, 5 minutes for last 2 years, and then for last year. This, to me, is good. Some years back, it was nowhere near this. I think there's an improvement, even though we can do more. Average dispensing time, 120 seconds for 2024, 135 seconds for 2025. percentage of prescribed drugs that were dispensed, we had 87%. And percentage of drugs adequately labeled, we got 100%. Percentage of patients with knowledge of correct dosage, we had 98%. We conducted exit surveys for client satisfaction, and it incorporated assessing the medicines to see whether the clients had good knowledge on them. This was done in Bole Hospital, and it is part of what has been put here. Okay. The region does not have a regional medical store. So in terms of the pharmaceutical supply management and financing, there are some of the places we didn't have data to present on. And so those are the areas being showed as it is. So we'll move on. We have some expired drugs that we have disattached. Maybe I'll just leave it and then move on to our achievements next. With respect to achievements for the region, the region conducted a baseline survey on antibiotics usage in the region in collaboration with the quality improvement team of the Bole District Hospital. And we disseminated findings at the just ended APR, that's the annual performance review, at Damango. The Bole Hospital is one of the centers for excellence as far as quality care is concerned. The level 4 pharmacist safe care assessment. And so quality is one of our hallmarks in that particular facility. We implemented a medication error reporting system, resulting in a significant reduction in medication errors and resolution of all errors detected. We coordinated activities with Northern Regional Medical Store, leading to the availability of essential medicines in the region. Pharmacy managers were retrained on how to conduct RUM and disseminate findings at their various facilities. This led to the improvement in the RUM indices, especially the marginal reduction, because once you are on a downward trend, that is good. And entry into DIMS. Some facilities were actually not entry into DIMS, but with this retraining, the down entry is good. In terms of conclusion, we are saying that the pharmaceutical service report highlights the progress, achievements, and challenges faced by the Pharmacy Directorate in the region over the past year. Despite the challenges, the Directorate has made significant strides in improving pharmaceutical services, ensuring access to essential medicines, and promoting medicines. The baseline survey of antibiotics usage in the region sets the tone for antimicrobial stewardship in the region. It is my hope that the department can do more in the coming years to improve pharmaceutical service in the region. Our recommendations are these. There's the need for more pharmaceutical service staff to be posted to the region. I know it is a national challenge, but I think the new regions are suffering. There's the need for the establishment of a medical store for the region, or to renovate the existing warehouse as a temporary medical store. In terms of the medical store, we have been promised a new medical store. So section of the core management at the regional level thinks that this is a priority region and we are going to get a new medical store. Why waste our resources to renovate this warehouse? Others also think that let's renovate it and start something from now. Those who think that a new medical store is coming and then there's no need for us to waste money seems to be over. This is the reason why the medical store is still a bit problematic. They think that we'll definitely get it, and whatever we're going to put over there is a waste. Number 3, the need to establish district in the existing 2 districts without hospitals. This one, we don't have the power over it, but I just put it there. That it's a district. There is the need for us to have district hospitals for them. So that is what it is. Now, with respect to our next steps, we want to lobby management for the establishment of the temporary regional medical stores. As a standard, even if they promise us one, and there is something we can do on something, we can do and start it whilst waiting for whatever is going to come. We need the number 2, identify and train logistics support officers in collaboration with the district directors to manage pharmaceutical logistics at the health centers and CHIPS level. This is what I said earlier. Most of the debt stores is hanging at the health centers and CHIPS. And so it's a huge problem. So I proposed that there's the need for us to train officers in collaboration with the district directors to serve as logistics focal persons for the districts. And these officers will be in charge of pharmaceutical logistics at the CHIPS and health centers level. Thank God this idea was accepted, and then plans are underway for me to give training to these officers for them to kickstart their work. And then, last but not the least, to collaborate with the Northern Regional Medical Store for the supply of essential medicine. We will continue to collaborate with them. For now, that is our only source of essential medicines. So with this, I say thank you so much to everybody. Thanks for listening.
Thank you very much, Dr. Mark. We are grateful for this excellent presentation as well. We've had 2 great presentations from Oti and Savannah, and at this time I will open the floor for our questions, our contributions, our comments. So the floor is open, please. Any comments at all? Okay, then I will.
Hello.
Hello, yeah.
Hello. Yeah. Thank you. I want to thank the 2 presenters for the good job they have done. My question really goes to OT. First, I want to commend them for starting some temporary structure for their medical store and distribution of the NOP medicine that came in. But then their debt recovery rates on the first year was 0, as I noted. And the second year, they said they are being aggressive and they were able to recover some debts. I want to know how they went about it. The second year, and to recover the debts, how they went about that.
Hello.
Hello, yeah, please go ahead.
Okay, my question goes to Oti, and not a question, but a recommendation. And I think he did a very brilliant presentation. I envy his report. In fact, he did very well. But what I saw was on the RUM. The question was maybe antibiotic dose, but he was still putting the percentage on the figures, with the figures. I don't know if you can maybe do away with that. Thank you.
Thank you for that question. Okay. Before Nii goes on, any more? So it's mainly OT that we commented on. For Savannah, nothing. Adam, please, do you want to say something? Go ahead.
Yeah, so to Savannah.
Okay.
He also did a very good, wonderful presentation, but my concern has to do with the tax shifting in the pharmaceutical sector. Is becoming a problem, and he has also noticed it and decided to train non-pharmacists or non-pharmaceutical cadre to do pharmaceutical service delivery? To what extent is that training going? And also, will he also be suggesting to them to also recruit people and pay them from the drug account to manage pharmaceutical service delivery, to understand the need of a pharmaceutical cadre to manage supply chain instead of excessive training of non-pharmaceutical cadre? That's what I want him to explain to us.
Okay, Adam, thank you for that question or contribution. Before I allow them to answer, I also want to say a few things. I'm really impressed about the report that came in from OT and Savannah. It looks like there's been a lot of improvement in our data capturing, which we are very, very happy about. So very well done. And the presentations were also excellent. They were right on point. So I commend the two of you for a good job done. A little thing I want to ask Uti also is the report on pharmacists being recruited. You mentioned most of them being at CHAG. I think 3 pharmacists being employed and they are CHAG, and some technicians too are CHAG. So I wanted to find out, is this whole report for both GHS and CHAG, or is just GHS facilities that you reported on? Because if you are reporting on the workforce or the personnel aspect and you are lumping it with CHAG, is it that the whole report you've added CHAG, or just on that aspect of the personnel, the workforce that you added CHAG? I want some clarification on that. And I think that...
Hello?
Yes.
Hello?
Hello, Chief.
Yes, please. Can I have a bite on this aspect, Savannah region presentation?
Okay, please. I'm almost done with mine, then I'll call you.
Oh, okay.
And then the numbers in terms of total facilities I wasn't in the written report, it says 260, but you were mentioning some 5, 6 something. It wasn't so clear. There was some disparity over there. And just to add on to what Adam is saying, Mark, I want you to come again when you want to train supply chain officers in terms of
Logistics support officers
for supply chain, pharmaceutical supply chain. Because I agree with them. The challenge we are having is all the supply chain issues that are coming up. It is our people that train the supply chain people, and now they want to take over. But so you trying to empower them again, I see a bit of a challenge there. Your intention is excellent. There's a gap, there's an issue, indebtedness is high, and we need to solve it. But in solving this, we have to be careful from what has happened in the past. Let's tread cautiously. Even if it's non-mechanized technicians that we need, I will encourage us to lobby for the districts to employ non-mechanized technicians, and then you train such people. But to train the people that will cause you problem, I see it to be a bit of a problem also. Thank you. So I will ask Chief Memory to ask his questions, and then you can answer all these. Chief Memory, you have the floor.
Okay. Right. Thank you, Madam Edna. I think you've just made my point. I also had a similar concern that if you look at the current happenings, we have to tread cautiously. But let me say that he made a wonderful presentation. But there was an aspect he mentioned, which I thought the focus should have been on that, about getting farm techs positioned at the DHS to support, coordinate these logistics management activities. I think that's a brilliant one. If he can focus his attention on that, I think that will help. But to the extent of training this non-pharmacy related stuff as tax shifting, it has its future consequences, and we have to tread cautiously on that. Your current happenings have open eyes, and if you are not careful, we'll be digging pits for ourselves. So that is my candid view. And now that we are hearing clearance will soon be made available, I think we should focus more on getting farm techs and pharmacists into the system so that we can strategically position them at the DHAs and at the NOP facilities so that it will help ease the pressure. This problem is, it's all over, especially the northern parts, but we have to be careful how we go about it. Thank you.
Thank you. Thank you for all the questions. So, just as the presentation came in, so family, please, can you respond to some of them?
Thank you. Thank you, Dr. Edna. So there was one recommendation and then 3 questions. So the first one, the recommendation on the percentages, I've taken note of it. Thank you very much for the recommendation. The first question, how we were able to go around the debt recovery with regards to the NOP. So for the first year, the main challenge we had was facilities complaining that they haven't any sense, so they can't pay immediately for them. The following year, and then now, what we did for first quarter 2026 was that regional director, and specifically himself, DDF, Deputy Director of Finance, and myself were supposed to prep our team to start paying. So regional director met the medical soups and the district directors. Then Deputy Director of Finance also pushed the heads of finance at the various districts and the hospitals. And I placed on really worked. Everybody wanted to be good because you don't want to be. So that's anything for us. Good recorded, right? On the yes, so the data so it includes the reports I got from the CHACFAS. So St. Mary Teresa, St. Joseph's, quite recently St. Luke Hospital. So yes, it includes that for CHAC as well. And then the remark on the facilities. I think in the OTCMS, the number of facilities, it was entered as 15. That was not a right figure. The validated figure I got from the Pharmacy Council now is 262. So 262 over-the-counter medicine sellers. So when we add that up, the total figure will change to 507 facilities. So I think that was the comment I meant to make. Thank you.
Thank you, Nick, for answering all those questions and taking those. So, Mark.
Hello.
Yes. Please, we are listening.
Thank you. Okay. I think it's misheard or misunderstood. I said we are going to identify logistics support officers among the pharmacy technicians in the various districts. And I said, even if it is one technician in that particular district, we will train the fellow, give him additional responsibility, or relocate him to the health directorate. So the focus is on the pharmacy technicians. Given the terrain of Savannah region, the focus is on the pharmacy technicians. So that issue is resolved. Thank you so much.
Okay, thank you for coming, Afielda. Thank you. Please, any further comments from anyone?
Yes, I think I want to thank the two presenters for a wonderful presentation. But I would like to ask Savannah Region if they can share their education error system they put in place with headquarters for us to study it and see if we can adapt it or replicate it for the whole of the country. Thank you.
All right, Savannah, thank you. So we will contact you for that. On that note, I think we've sat down for quite a bit. We would like to take a 5-minute break and then come back at, let's make it 10 minutes. Come back at exactly 1 p.m. Exactly 1 p.m. So we'll take, let's say, 9-minute break, come back at exactly 1 p.m. And at 1 p.m., we will be having Western North Ahafo presenting for us. Western North and Ahafo, please get ready and you'll be presenting from 1 p.m. exactly. Thank you. You may take a stretch.
Woe to me so now ye beka what you man yeah every sad what you man yeah can see oh sa bury my who to me so chef for pie. Oh, Dima for pie. Woe to me so. Woe to me so. Sabe man. Oh, woe to me so. Woe to me so. Osa bury my woe to me so, woe to me so. Osa bury my woe to me so, woe to me so. Oh, Sabe, Rima, Daddy would to me so, woe to me so. Na ye beka, would you man nara? Every say, would you man ye kesi? Oh, sa bury my woe to me so, woe to me so. Na ye beka, would you man nara? Yeah, every sad, would you man ye kesi? Oh, sa bury my woe to me so, Oja for pie, Odima for pie. Woo to me so, woo to me so. Sabe bima, aye, oh, ah.
Okay, so welcome back everyone. We will go ahead with regional presentations. Western North is next. Western North to be followed by Ahafo region. Western North and then Ahafo region. After that, after these two, we will take questions and then we'll take 3 presentations and then we will close for the day. The 3 presentations after this batch will be Bono East, Central Region, and Upper West. The last batch will be Bono East, Central Region, and Upper West. For now, we're going to have presentations by Western North and Ahafo region. Thank you. So Western North, your presentation is up. We are ready when you are.
The regional pharmacist, chief pharmacist for Western 5 regions, a total population of 325,020. Okay. Yours are found. Hello.
Hi, Mickey. Sorry, it's the network that disturbed it. We will bring it back up.
Let me switch it. Okay.
It's back up. It's back.
So the faith-based hospitals are 3, then quasi-government 1. Okay. Okay, let me. Auntie Edna is having challenges controlling. Okay. We have 18 model health centers and NOP health centers. The non-NOP health centers this year, 17. A total of 258 CHIPS compounds. The over-the-counter medicine sellers from the Pharmacy Council 721. the retail pharmacies 32. So giving us a total number of facilities as 1,072. 1,072. These are our specific challenges as a region. The first one is inadequate numbers of trained pharmacy staff, mostly pharmacists and pharmacy technicians. We would see we have only 7 pharmacists for the whole region. High antibiotic prescription and usage is also another problem or challenge. And we realize it is even worse in the health center. So that is an issue that as a region, we've noticed as part of our challenges. The absence of regional medical stores is also a challenge from here to the regional, where the regional medical stores, Western region, it's about 6 hours drive. So it's a very big challenge, especially though they are doing last mile distribution. In terms of emergencies, it becomes very difficult getting medications. There's also poor pharmacovigilance and poor adverse drug reporting. That is a very big challenge we're also battling with as a region. Low tracer medicine availability. This one is a particular challenge when it comes to the sub-districts. At the hospital level, it is a bit okay because Western region medical stores are actually helping a lot. But when it comes to the sub-districts, it is still a challenge. Then data inconsistencies and loss of data through the electric. We realize most of the facilities were not keeping data, they're backing up themselves. They relied solely on the electronic system that we were using. So when we had that challenge, it also affected most of their data. As a region, our priority include exploring ways of improving the numbers of pharmacy technicians. And this one, through advocacy, we are SMC, Human Resource Manager, Human Resource Unit of the region. They are all working very hard to do that. And as a stopgap measure, we have some of our technicians on steady leave to pursue PharmD. And with that, at least for now, we have 7 of such staff pursuing PharmD, and we hope in the near future, at least they will come and augment the number of pharmacists that we have in the system. We also want to improve our RUM indicator, especially antibiotic prescription. And as a region, we have we've institutionalized antibiotic stewardship activities in the hospitals and health centers. The clinical care unit of the region has also taken antibiotic overprescription as their challenge project. We working with BMC's heads and pharmacy supply managers to also improve our tracer medicine availability. We realize most of them don't even know their consumption patterns, their order levels and those. And so the region has taken it up to train them so that those that are in charge will know what to do when it comes to requesting for their medications. Then we will also, as a region, want to scale up the training on standard practice and guidelines of it was done for the hospital pharmacists, and we want to scale it down to the technicians and pharmacy assistants as well. Can we please? Then we've identified a structure that we want to use as our medical stores. So we will want to continue stakeholder engagement so that we can get funds to renovate, do a few things on it, and see to its operationalization. Then we also realize ADR reporting and pharmacovigilance in general is a very big issue here. So we are in consultation with FDA to work on that through trainings. They had some about 2 or 3 years ago, and it's improved. And we realized we need to redo such trainings to further improve the number of reports that are generated. We know they are happening, but just that we are not sending them. Pharmaceutical workforce management. Last year, we didn't have any staff posted to the region. In terms of mechanized staff, at the moment, we have 8 pharmacists, including myself. At least every hospital, we have 8 hospitals. So a gap of like 30. Pharmacy technicians, we have 32 at the moment in the hospitals and health centers. Then dispensing assistants are 12, giving us a total mechanized staff of 54 and a gap of 116. With the non-mechanized staff, one hospital has employed a non-mechanized staff. The number required here, I put it there because there are requests we got from some hospitals and health centers that they wanted to employ, but most of them were turned down because if you are not servicing your debt at the medical stores, it becomes difficult how sustainable it will be for you to add on some of these staff, pharmacy technicians. So for the non-mechanized, we have 12 pharmacy technicians, 54 and 67. We had about 28 applications, but most of them were turned down. Can we please continue? So with the pharmaceutical staff complement with regards to both mechanized and non-mechanized, 168, 54 are post now, and a gap of 116. Clinical services. So the total number of OPD visits, 1,008,553. OPD per capita, 1.2. It improved from 1.06 in 2024. Number of admissions, hospital, and total number of under 5 hospital admission, 14,758. total major surgeries to 2,400 and minor 10,620. Pharmaceutical care. So total number of prescriptions served 43,680. Apparently, the 2024 report, nobody reported, none of the facilities reported on that because it was not part of that year's business. So most of them did not capture that data. But with 2025, data was available. The average prescription per day, 1.182. Insured clients, 560, and the revenue component is about 11 million 400. We realize the insured and non-insured, most of the clients are insured. About 80% of the clients that are served are insured. Okay, interventions. These are the figures for interventions. Can we please go up? No, go. No. You are going up rather. Okay. So in terms of clinical ward activities, we have 20% completion of pharmaceutical care plans, 80% resolution of drug therapy problems, and discharge counseling 60. Then emergency medicine accessibility at the wards was 70%. With patient safety, these are the proportions. About 82% due to medication errors due to prescribing, 9% dispensing, and 6% administration. Please, can you go on? So of these, no harm, 14 of them were temporal harms, and they were mostly as a result of allergic rash and other reactions, simple reactions, and most of them were all resolved. There were no deaths or permanent deaths. And these are the source of the reactions. Can we continue down? So, like I was saying, the outcome of the ADR reactions, we had 13, recovered 13. It's only one person that was hospitalized, but that person also recovered. So a total of 14. Rational use of medicine indicators. These are, the challenge was with antibiotic use, which worsened. And we realized it was due to one health center that was upgraded as to a hospital level, and their first and second quarter antibiotic prescription was over 80, and it's affected that of the region as a whole. That is what necessitated the region, the clinical care team of the region, in consultation with the pharmacy as well, to pick that one as our challenge project to ensure that we bring it down to the standard that it's supposed to be. Can we go to the challenges and we don't have a medical store, so this session, we don't have data on it. Western Regional Medical Store will present on our behalf. That is why I want you to go to. Okay. So achievements, we have improvements in our tracer medicine availability, especially at the hospital level, from last year's figure of 65 to about 69.7, almost 70%. And this one, we would want to acknowledge the help we get from Western Regional Medical Stores. They've improved on their tracer medicine availability, and it is also reflecting here. We've also improved on our NHIS claims adjustment rate, especially at the hospitals. Most of the hospitals are now doing less than 5%. Then securing a structure to be used as a regional medical store is also an achievement. Conclusion, I would say the inadequate numbers of pharmacy staff, especially pharmacists, continue to affect the quality of pharmaceutical service rendered. But notwithstanding all these challenges, the few staff are well motivated to work towards improving and maintaining the highest standard of pharmaceutical care. Recommendation: the need for more pharmacists to be engaged, antibiotic stewardship. We've learned a lot of lessons from not backing up. And so all the pharmacy units are now doing that. And next steps, we want to ensure that antibiotic usage is reduced to the barest minimum. And like I said, it's a challenge project by the clinical team. We've also started the formation of institutional antibiotic stewardship teams. There is training on RUM, especially for the sub-district, to help them as well improve on their RUM indicators. FDA has been contacted to help in our training concerning pharmacovigilance and ADR reporting. And also, the agents need to improve the numbers of pharmacists and pharmacy technicians, and thus the region is trying to make sure that at least what we have, we upgrade them so that the pharmacy technicians will become pharmacists, and pharmacy assistants also upgrade to increase the numbers of pharmacy technicians. Thank you.
Thank you, Pamiki, for the good job done. Thank you. So we'll take the one from Ahafo region.
Hello, good afternoon. Good afternoon.
Yeah, good afternoon. We can hear you.
Oh, okay, great.
Good afternoon.
So, this is the report from Ahafo region, one of the newly created regions. So, our population for 2025 is 6,477. So, we have 6 districts, which has not changed. Then 27 sub-districts. The regional hospital there is not full-fledged or officially, but we assume the Goso Government Hospital being at the regional capital as the regional hospital. We have the 6 district hospitals. The public is 6 and the private is 8. The field-based, we have 3. Quincy, we don't have. The model health centers, we have 8. NOPs, 14. Chips compound, we have 66. In fact, I just had the retail as 46, which we will fill in later. And then the OTC as 458. I just had the information. Okay. Please, let's move down. So, for governance and leadership, the region-specific challenges are not new, my other colleagues. So here we have regular stock out of essential medicines, including the psychotropics. Then difficulty in obtaining non-availability certificates is also an issue in the region, because the region, we don't have our own medical stores. The delay in reimbursement, which cut across. Then our facilities have a small dispensary workplaces. There's some huge NHIS rejections in some facilities, and usage of GLMS also has some difficulty getting internet connectivity. Low availability of some key tracer medicine, especially in our sub-districts, and then inadequate workforce for the pharmaceutical service. We also have non-functional DTCs in some of our facilities, which are affected our performance, like the high usage of antibiotic, and then the huge facility indebtedness to our friends at Bono, where we get most of our medicines. Okay. So regional priorities. We will continue to lobby for pharmaceutical workforce. The region is looking forward having funds to refurbish the temporary RMS at Kenyase, where most of our NOP medicines are stocked. The region also, some of the NOP medicines, our facilities are not paying, and also paying the Bono. So we have huge indebtedness, which we want to carry out debt collection. We also strengthen our vetting committees, claim vetting committees, to reduce the NHIS avoidable rejections, and work closely with our DTCs to reduce the high usage of antibiotics. We also want to train pharmacists and pharmacy technicians on the standard and practice guidelines. We have not scaled out to our facilities, apart from some of us who attended the program for launching. We also collaborate with the Bono FDA to train in respect of pharmacovigilance. Please move forward for me. Forward. So the pharmaceutical workforce mechanized. As at now, specialist 3, we have 12 pharmacists, and the gaps are there. We have 24 pharmacy technicians for now. The MCs are 11. So for total mechanized staff, instead of 118, have 50, and we have a gap of 68. For non-mechanized, we require 21, have 17, so we have a gap of 4. Okay, so the total 139 at post 67, so we have a gap of 72. So the remarks is we need a prudent pharmaceutical workforce with that. For clinical indicators, the OPD visit is there. The OPD visit per capita has increased small, which is a very big 1.54. The OPD visit for insured and non-clients, total number of admission for under 5, hospital admissions rate is there. The surgeries, the major surgeries has increased compared to 2024. 1,475 up to 4,000. There was a huge increase but for minor surgeries, it decreased. Once the major one increased, the minor has decreased. So the total number of deaths is also there. For pharmaceutical care, which can move down. Good. So this is the RUM. No, this is not the RUM. This is the total prescription sales per month. I will see. Then per day, total number of clients is there. Some of the information I didn't get, I'll get it later and then fill in as we move forward. So like the out-of-pocket revenue and those data I didn't get. Okay. So the total intervention for 2025, we have 75. We had the information for the drug therapeutic program result, which was a percentage of just 20%. We didn't get that data for discharge counseling, but the emergency medicine availability, because of the peer review, we had it, and that one we had 93%. Okay. So for medication errors, the prescribing was 75, but most of the issues were just for prescribing errors. So 68 were for, most of them were just OPDs with prescribing. So most of them were solved even before it was dispensed to a patient, because they were found out before. Then the other dispensing was just few. Please move forward. So for the outcome, no harm. Most of them, because I said it was trashed out before it was dispensed, no harm was caused to any patient. Okay. Please move down. So for the ATC, the classification, most of the ADRs we have were for the antihypertensives. So the 75%, so about 40 of them. So 30 were for cardiovascular, and then just 2, which was 5% for the alimentary tract and metabolism. Most of them were for cardiovascular medications that we had. And then few had the genitourinary system. Was from one Cipro fluoxetine tablet that we had. Okay, so the outcome, like I said, there were 40. So the whole 40 were recovered. There was no harm because it was tackled before it became too late. So this is our rational use of medicine. So for 2024, the average number of medicines, 2.9, increased to marginal increase of 3.0. So we are still within the range. The generic prescription came down from 98 to 96.4. Antibiotic is still high, 42.6, still 42.4. So the antibiotic usage in the region is very high, which we are tackling in this year to reduce. Injection is still within 4.8, 4.7 for 2025. Then the essential medicine list, the percentage increase from 95.6 to 97.7 for 2025. For average consulting time in those, I didn't get that data, but going forward, we'll try as much as possible to fill in. So, percentage of prescribed medicine dispensed. Now we had it from the RUM. So it was 80% for 2024. And 2025, it has increased to 85%. So once we don't have the regional medical store, most of these indicators we didn't get. So we move to the achievement. So for the achievement, we had some achievement, only that was put there as non-applicable. So we had the pharmacovigilance training with the FDA, where they train the pharmacists and the pharmacy technicians and other institutional contact person at Dua and Kwanta, which was very successful. The system for development people also came in when we wanted to onboard our health facilities, especially the health centers and the chips for the supply of NOP medicines. They came in and there was a training for that. So now all our health centers and chips are boarded. There were also a lot of supportive supervisions. Some of them were pharmacy alone, where other senior pharmacists went to a lot of our facilities to carry out supportive supervision to augment the work that our health facilities are doing, especially the sub-district. There were other supportive supervision which were integrated, and therefore the pharmacy were also well represented. The peer review also came in, which the pharmacy department also represented. And then when even we took up, because there is no medical stores, and for the NOP medicines, there was no even software for the invoice. So people were coming to the temporary regional medical store for their NOP medicines, and we were using issue vouchers as invoices. So we had to put in a tally software, which the region did. So with the next steps, we are praying that for the year 2026, we will continue to train our clinical coordinators and the pharmacists in our regional hospital, district hospitals on the rational use of medicine, especially with the high usage of antibiotics, and then how best we can. Then we also want to do quarterly meeting with the hospital pharmacists, where we will analyze data that will come from their facility, so that we'll see where the gaps are. Another thing that we have not done, as I said, is about the training of our pharmaceutical staff on the standard and practice guidelines. This year, we want to do that training so that we will scale down reporting. That has even affected my report because they are not aware of what they are supposed to report. And therefore, most of the indicators I didn't get. So I pray that with that training coming in, we'll get in the report and feed the region as well. Thank you very much.
Thank you very much, Ahafo, for staying within the time. And thank you to both of you, Western North and Ahafo, for the presentations. Before I even open the floor, Ahafo, I think you admitted it. So we will do a resubmission of this form where you fill in the achievements and conclusion and recommendations that you told us, please.
Okay.
And then I think previously to there's some data that you've received You mentioned some gaps in the.
Yes. For the retail pharmacy and then the OTC.
Yeah. So you feel that one as well, and then we will make the research. Okay. On that note, please, I'm opening the floor for our questions and contributions. The floor is open to the House.
Okay, thank you, Doc. I think I'll take the first question. But I want to thank both presenters. It was a very good presentation. For Western North, the total number of OPD visits, they seem to have had the same figures. I don't know if they can explain or comment on this. For 2024, it was 1,008,553, and was same for 2025. It looks quite simple. Thank you.
Please, the floor is open to all. Either he confused us or we're not paying so much attention to it, or he did such an excellent job that he doesn't even need room for improvement.
Auntie Edna, let me ask this question.
Yes.
Dr. Phillips said the NOP medicines are not being paid for. May I know the reason? Were they thinking it was for free, or why? Why are they not paying?
Oh,
Thank
okay. Yes. Please, can I
Hello,
respond?
Can I also ask the question? Thank you, the two presenters, for the good presentation. My concern goes with Ahafo, my former region. I think we are doing well with the antibiotics. We are now at 42. I remember going there and the antibiotic prescribed was 80%. And it was a huge thing at our performance review. So you need to do more to bring it down. And I'm happy you are coming down the ladder. But with this delayed NHIS reimbursements that we're talking about, these NHIS, they are reimbursing quickly, because in my region, some have even received up to December last year. They are just 3 months in arrears. So if they are not really paying, then not that their NHIS is not paying them, NHIS is recently paying them. And so the debt collection system has to be robust in order to recover all this cost. Then my second concern is actually, what is the challenge that you are having in training your pharmacists on the standard and practice guidelines for pharmaceutical services? It's been a bit delayed. What exactly is preventing this training carrying on? Thank you.
Okay. Please, can I respond?
Yes, please.
Okay. So the first question was on NOP medicine. Why are they not paying? Yes, I think your guess is true as mine. At first, even some of us thought it was free. So the first allocation that were done to our facilities, that was the idea. Till later on, the information came that it wasn't free. So I don't know, maybe that affected the management or whatever it is, management of the medicine at the facilities. But later the information came that it wasn't free and then they have to pay for it. That's where probably the issue came in. So now the policy is that it's not free. Facility will have to pay for it. NHIS indebted, yes, as my boss said. And as to when we were putting in the report and we started this report, a lot of facilities were being owed by NHIS, but just before last week and this week, I've heard like saying that they have reimbursed about 1 or 2 months. But at the time of putting in the report, the facilities were suffering. Some were even find difficult to pay their non-established staff. So director is true for last week and then this week I have heard that probably there has been some payment. So we will go ahead for the debt collection for both the Bono and then the Ahafo. Training of our workforce on the standard and practice guidelines. That is true. My former boss, you see, I'm acting boss, you were also there. They made a proposal and look as if the proposal for the training was a big, huge. So recently I had a meeting with our regional director of health service, also put forward for the training. He also saw the bill, he saw it to be big. So he said we should review. At first we thought we could do it for maybe 3 days. So he said if that's the case, we should reduce it to either 1 or 2 days and present again so that we can. So the main issue was the bill. And then the main issue was how also to converge all of them at one place for that period. So if we are able to reduce it to maybe 1 or 2 days, I think with that proposal, it will be accepted. We pray that by the end of this year or by the half of this year, that training will come on. Thank you very much, my former boss.
Thank you, Chief.
Hello, okay, Chief.
Yes.
Okay, Chief Felix, yes, I think it was a typo error. The total OPD visit for 2025 is 1085002. I think I repeated the same for 2024. It's supposed to be 1085002. Thank you.
Okay, thank you for that correction. A question from Director, please.
Okay, so thank you, Dr. Edna, and let me commend all presenters for the detailed presentations made. The questions that colleagues followed up with also indicates that people are listening to the presentations with rapt attention. I'm most grateful to you for that. We are still monitoring the number of participants. It's around 89. We expect more. So 91 now. We expect more. So please kindly remind your constituents to join for this capacity building workshop, more or less. I want them to also know what their input is resulting in the performance, how the input is also affecting the performance of their respective regions. So it looks as if the burden is only on the regional head. They must know that data that we use here basically comes from the lower level. So they must get deeply involved. Having said that, Afro region, maybe I'll ask some few personal questions. I want to know what has become of the copies of the standards and practice guidelines that were given to your region. Are they still with you or at the IRD or distributed them? Secondly, I'm the regional parent for Africa. I was there at your 2025 annual review meeting, the month of March. I didn't see you. Do you have any reasons for not participating in a review meeting? I also realized that during the annual review meeting, your NHIS adjustment was about 3.33, and that one of the lowest across the nation. But you said that we have high NHIS for some of the facilities. Can you clarify that? Western North, we thank you for the efforts that you are doing to institutionalize antimicrobial stewardship in your hospitals and health centers. Please, can you update us on the efforts made so far and the outcome thereof? Thank you very much.
Okay. Please, can I respond? Let me attempt to respond.
Yeah, right.
While the director is a regional parent, so we can't hide anything from him. In fact, during the program, I was indisposed. So I sought permission and I couldn't even attend for the annual review, as you said. For the copies of the training manual, it is at the region. It is at the region. So we had wanted to share, but at that time, Van Brichum said, no, it's better probably we'll do the program and then share it accordingly. But now we'll try as much as possible, even you can see if we can even share before the program. So the copies are there, it's at the Regional Health Directory. Okay. For NHIS rejection, that is true. 3.2, according to the data, it is less than 5%. They are saying within. But just last 2 weeks, we had a meeting with some of our auditors, and they were saying that they are not looking at the percentage or whatever under 5.4, but they look at the value. That is why probably I said a huge. When you compare the value, the auditors look at it as a huge. They are not enthused about either is less than 5% or not. But I can see the region, we are not doing badly. Thank you.
Thank you, Chief Poku, for Acting Chief Poku, for your explanations. And thank you all for your excellent presentation.
Thank you.
Famiki, please.
Okay, thank you very, very much, Director. With regards to what the region is doing to institutionalize the use of how we're going to reduce antibiotic usage. One, I said in my presentation that it has been recognized, the pharmacy unit during our annual review as a region, it came out last year. And so as part of the things that the clinical care unit of the region wants to do, it has picked up we wanting to reduce antibiotic usage within our facilities as our challenge project. So that is the first thing. And we've also started the formation of teams within the facilities to ensure that they will help sensitize the prescribers. And this one, we've empowered the DTC especially to make sure that the antibiotic stewardship teams that have been formed really work. And we don't want it to be the tax of only the pharmacy managers and only. So we want the DTC as a whole. So the DTC with the clinical coordinator, pharmacists, and other the nurse manager and those members of the DTC to ensure that the stewardship teams so formed are working. And as a region, as part of our efforts, the team, the challenge project team will also be going around to see what they are, the teams so formed are also doing in the course of the quarters to see to it that the prescription of antibiotics is reduced. So one, there is a challenge project picked by the clinical care team. We formed antibiotic stewardship teams, and we've empowered the DTC to ensure that these teams so formed are working effectively and efficiently. Thank you, Director. Then the last thing is also we've asked the institutions to also have an institutional antibiotic protocols based on the standard treatment guidelines. They realize sometimes they have this particular range of antibiotics, but especially the hospitals that have PAs being trained there, we realize they are also part of the reasons why, because we don't have a lot of prescribers. When they come and they are under training, they sometimes prescribe and they don't follow the institutional protocol. So we want them to take them through the institutional protocol based on STG so that they will not just be prescribing antibiotics, but following the protocol. Upper respiratory tract infections, no antibiotic. And that is what is there. And they come and they have to follow the same protocols. Thank you very much.
Thank you all for your presentations, your answers, and your comments. We are grateful. We'll move on to the next batch, which is the last batch, starting with Bono East, to be followed by Central and then Upper West. Bono East, Central, and Upper West. And we will wrap up for the day. So please hold on and hand.
Yes, Auntie Edna.
Okay, you are ready. All right.
Yeah.
It will be projected in a minute.
Okay.
Sir, it's on now. Please.
Okay, thank you very much. Good afternoon, Director and colleagues. So this Bono East background. The landmass, the total population is the same for 2024 and 2025. This is gone. Good. So the landmass is also the same. The number of administrative districts, 11, 2024, then the same 11, 2025. The only changes are the private hospitals that moved from 13 to 15 in 2025. Let's move on. And then the non-NOPs were 18, 2024. It has moved to 2023. The NOP is still 21. Let's move on. Let's move on. Governance and leadership. So region-specific challenges were inadequate pharmaceutical service personnel, both pharmacists and pharmacy technicians, as Director said before. We don't have them at all within the region. And we have hard to reach areas. Sine East, Sine West, Pro East, Pro West. And we are having issues over there as far as our pharmacies are concerned. Then there is unsustainable revolving drug funds at the health centers and the cheap compounds. And as we get down, we get to know that they are owing a lot as compared to the hospitals. And we don't know what is happening. There's also inadequate seed capital for the regional medical stores. We were depending on Bono indebtedness. So those who were not paying were asked to take those monies to run the medical store. So we see where we are coming from. It's not easy for us. Although we have a medical store, but it's not easy. And there's erratic payment of national health insurance claims. You know, for some of the areas like Atebubu, for some time they were not receiving payment, and it was a big issue for them. And then our data is also very unreliable, very, very unreliable. So like what is being done for us currently, that we present our data through some format and it is collated at the national level, I wish we also do same over here, that when the hospitals send their data, we also get them, and it will help us to get the data very accurate. Because at times you want to pick it from here, pick it from there. At the end of the day, what you'll be getting will not be what you're expecting. And there's no means of transport for that. Chief pharmacists, as well as no accommodation. Then these are the regional priorities that we will liaise with headquarters through director of pharmacy to help us with staff. In fact, we are suffering. Even at the medical stores, we don't have a single pharmacist, only have a technician. And it's not easy. Some of the things is not easy. And I cannot be going up and coming down as well. It's not easy at all. Then, as at 2025, we have some of our the head of pharmacists were not signatories to the evolving drug fund, but currently all of them are part of the signatories. Then also plan that there should be quarterly debt collection to improve on capital for the running of the medical stores. Then quarterly validation of data to prevent data disparities. Then quarterly supported supervision. And then join any available vehicle. Once we don't have vehicle, people are keeping their vehicle as their own. And it's not easy using your own vehicle. Most of the times for the good routes, I use my vehicle, but for those rough terrains, it's difficult to. We had no postings of pharmacy staff for the year 2025. So let's move on. We have 2 specialists. One is cardio and one is infectious specialist. Pharmacists, we have a gap of 18. Pharmacy technicians, we have 22, a gap of 30. Dispensing assistant, we have 1, a gap of 19. Then total mechanized, we have 34, and the gap is 74. Then for the non-mechanized pharmacists, we have a gap of 18, since we don't have any non-mechanized pharmacists. Pharmacy technicians, we have a gap of 17. Currently, we have 10, or as at last, we had 10. Then dispensing assistant were 8, a gap of 10. So total non-mechanized is 18, a gap of 45. Shall we move on? So in all, we have 52, both mechanized and non-mechanized. The gap is 119. Shall we move on? General clinical services. Total number of OPD visits, 2025, there was increase from 2024 to 2025. We had 2 million against 1.9 in 2024. OPD visit per capita increased from 1.42 to 1.53. Visit per insurance clients increased from 1.7 to 1.85. Number of admissions, there's disparity over here. Graphical error. It should rather be the admissions move from 119,028 to 125,260. There was a typographical error over there, sorry. The total number of infant admission reduced from 12,239 to 11,487. Total number of under 5 admission also reduced from 28,000 to 25. Hospital admission rates move up from 91 to 93. Total major surgeries move from 7,000 to 10,000. The minor one moves from 16 to 26. Death also reduced slightly, and then death per admission rate also reduced slightly from 16 to 15%. Pharmaceutical care, let's move on. Total prescription served was 29,000. The 2024 one, I couldn't get it. So 2025 was 29,691. The average prescription served per day was 1,059. Insured clients was 248,255. Then the revenue generated from it was 9.8 million. Therefore, non-insured, the number was 25,890, and the amount accrued from that was 3.5 million. Let's move on. Please, let's move on. Please, let's move on. Can you hear me, please? Good. Clinical ward activities. So complicated PCP was 100% for both 2024 and 2025. Drug therapy problems resolved was for 2024 was 835, and then for 2025 was 973. Shall we move on? And then all the hospitals are doing discharge counseling. Shall we move on? Patient safety and quality improvement. Total type of medication from prescribing, it was 920, we gave 99.57%. From dispensing was 0.32%. From administration was 0.11%, given a total of 100%. Shall we move on? There was no harm. Shall we move on? So there was no harm. Let's move. Sources of adverse drug reaction. We have imatinib leading with 29.6%, antihypertensive with 30.3%, antimalarials 20.39%, antibiotics 9.27%, analgesics was 5.26%, antiretrovirals was 5.26%. I would suggest that next time you be increase the numbers because some of them couldn't appear. The numbers were more than this. So instead of up to 7, we can make it 10. Thank you. Shall we move on? So none of them was hospitalized. Move on. Then rational use of medicines. For average number of drugs per encounter, they were all below the WHO standard of 3. 2024 was 2.72 and it moves to 2.82. For generic prescribing, it went 100% as against 99.67 last year, 2024. Then antibiotics. So like I said before, so anytime they type it in their end, it should reflect, because for antibiotics, in our annual general performance review for the region, it was 20% for 2025. So I think it is reflective. So instead of 19.5, it was 20%. So that is all right. Injection has always been low, below 20%. The rest are 100%. Shall we move on? Then average OPD consulting time was 20 minutes. The average dispense time was 5. Percentage of prescribing drugs that were dispensed, 90%. Percentage of drugs adequately labeled was 100. The percentage of patients with knowledge of correct dosage was also 100%. Shall we move on? Yeah, for pharmaceutical supply, please come down. I have the figure. I had it late. Come down a bit, please. Good. So framework contract for 2025 was 2,947,247.79. Then for non-framework, we are 10,927,506.00. As at the time that I was submitting this report, it was not ready. So that was the figure that I forwarded to National. Let's move on. So total purchases. Here too, we had issues with 2024 because we were still dealing with Bono. So this, the total purchases was all right because we then started in 2024. But the actual sales that were meant from ours was 1,403,474. But then when we add bonus 1 to 8, that will be bigger than this figure. But this from Bono East region. So the 2025 This was the purchases, 14 million, and then the sales was 18 million. So the total debtors as of 2024 was 20,764,88. So this one includes that of Bono region. And then ours as of 2025 was 28 million. That was one summary of the operations of the regional medical stores. So the net worth moved from 14 million to 28 million. The tracer medicines was 80.4 for 2024. In 2025, it moves to 82.14%. Move on. Move on. So the debtors for the hospitals and polyclinics was 6,144,364. But look at that of the health centers, the CHIP compounds, and so on and so forth, including the DHA itself, were 22 million. So the chunk of the indebtedness is coming from the district, the health center, the CHIP compounds. So the total is 28,347,432.41. Let's move on. This figure, I couldn't get it. I don't have a single pharmacist at the regional medical stores. So 2024, I had one who has left to pursue course outside the country. So 2025 figures, I couldn't get. Let's move on. So this is the working capital is over there. I've stated it. So far, our achievements, our conclusions, and recommendations are stated over here. For achievements, by the grace of God and by the fact of hard work, we are, as of 2025, we had about 50% complete of the production unit. So latest ending of April, we'll start production. By next week, we'll start with the for the detergents and then methylated spirit. Then after the second week, we may start with the extemporaneous preparations. We are almost done with the unit. I was able to visit about 45 facilities, including hospitals, polyclinic health centers, private, and so on and so forth. Then most of the Ghana service facilities have improved in their networks. Initially, when I started, some of the facilities were operating in negative networks. And for now, they've all improved with the exception of Kintampo SAT, which is still operating in negative network. But although they've improved, they are doing well. The pharmacist over there is doing very well. Kintampo Municipal Hospital used to be operating in negative network, but now it is operating in positive network and it's improving very fast. I was able to meet the head of pharmacy 3 times within the year, most of the time through virtual. And then the technicians, I was able to meet them once through virtual. I was able to join some facilities for ward rounds, at least 5 of them in 2025. So despite the challenges that we are having at the medical store, we're able to increase our network by 48.3%. And then tracer medicine availability also moved from 80.4 to 82.14. Shall we move on? In conclusion, we hope the Bono East Regional will perform better by the end of 2026, when we have a lot of logistics. Our funds for running of the medical stores has improved, and then the production unit has also started producing extemporaneous. I think we can do very well, and our network will increase. Then the recommendations. So lobby through Director of Pharmacy to help us with pharmacy staff. In fact, over here, we have a lot of hard-to-reach areas. For those of us who don't know YG, KJG, calm it down. So please do well and come and visit us. The road is not good. Aside that, most of them are being attacked by armed robbers. It's not easy to work over here in Bono East. So please, Director, we need your help. And aside that, there's no means of transport for me, and it's difficult going through to visit all your facilities. It's not easy at all. Then the next test, to improve on tracer medicines availability from 82.6 to 90, and also to improve on our fill rate from 65 to 70 by the end of 2026, to improve and sustain the antibiotic prescribing of 20%, is not 16.8, to conduct operational research on high antibiotic. This one we work on it very well. Now it has come down. We're visiting most of the time the high antibiotic prescribing was coming from the private facility, which I took most of my time and I visited them. I taught them how to go through that. And then aside that, we're having in-service training. So now the antibiotic prescribing is better now. Then also we are doing our best to reduce the indebtedness at the regional medical stores by 50%. And also to improve on supportive supervision 2 districts per quarter. And then also to improve on clinical activities in the region, daily ward rounds, medication interventions, pharmacovigilance, and pharmacy clinical presentations. And we are doing what we go on ward rounds, and I go on ward rounds with them. And then I'm also suggesting, like I said before, this new format of reporting should be sent to the facilities to fill and to be sent to the region for synchronization. That will help us a lot. I think I'm done. Thank you very much.
Thank you very much, Ifoku. The flights of Bono East have been well noted. I was there, so I understand. And also your recommendation about the reporting format to the facilities has also been well noted. And we'll be working on it.
Thank you very much.
Thank you. All right, on that note, we will call Central Region to give us their report as well.
Good afternoon, everyone. Thank you for the opportunity to present. So, by way of introduction, that's our total population. It appeared there was just a slight increment from 2024 to 2025. Please, let's move on. Yeah, so everything remained the same, land mass, all those things, they are all the same. It's worth noting that although we have 22 districts, we do not have a district hospital in all of the 22 districts. So we have, our district hospitals are, just about 11. Please, let's move on. Please, let's move on. Okay. So we got the total number of health facilities after I had submitted the report, and it's 779 for both 2024. Yes, it's both 779 for both 2024 and 2025. For the region-specific challenges, as has been said by the previous presenters, we have insufficient pharmaceutical staff. This one is referring to pharmacists, farm tech, farm assistants. There's high indebtedness of health facilities to the regional medical stores. You see the distribution when we get there. There's inadequate sub-district supervision by the available pharmacists in the region because, one, previously it wasn't part of the culture, and the dynamics have also not been streamlined yet. Then there's lack of standard storage conditions in some medicine stores in the health facilities. And we are also suffering from high antibiotic usage. For the high antibiotic usage, you get data to support it. You look at the top 10 diseases, you are having the upper respiratory tract infections, you are getting the urinary tract infections. So it's more like it's there, but then we would have to find ways and means of trying to curb it. When you look at the data, it looks as if maybe there's a data error, but then when you drill down, you realize that there are really conditions that amounted to that. So regional priorities to lobby for additional pharmaceutical staff, all the cadres, to improve debt recovery at the regional medical stores, to consolidate pharmaceutical supervisory roles at the sub-district level, to improve rational use of medicines indicators and activities of the drugs or medicines and therapeutic committees, and to also improve availability of essential medicines and availability of the regional medical stores. Please, let's move on. For the pharmaceutical workforce management, when we look at the pharmacists, we didn't have, please, let's move on. We didn't have any pharmacists posted to the region in 2025. What we have is what was posted, or the one who was posted in 2024, and that's even a farm tech. Then when we come to the mechanized staff, we see this huge gap. We see that we require 553. We have 86. And then we have the gap of 467 to beef up. That really explains most of the challenges we've been having with clinical activities at the facilities. Please, let's move to the non-mechanized. Yes, so for non-mechanized, we have a total of 96. Like the other presenters mentioned, in fact, we commend the facilities that have taken the lead or have taken the step to pay for the pharmaceutical staff out of their IGF. You realize that they are really helping, because when we compare mechanized and non-mechanized together, these non-mechanized staff has sort of reduced the gap. Please, let's move down. Yeah, so from the 467 we saw previously, because of the non-mechanized staff, although it's costing the facilities, the gap is 371. It would be good if everybody is mechanized, so that at least the little IGF that the facilities make can be used to rather improve drug availability and other issues concerning pharmaceutical services. Okay, so please, we move on to the general clinical activities. Yeah, number of OPD visits increased a bit. Yeah, there were just slight increments. It's just the number of admissions that were reduced, 176,000 in 2024, then 174,000 in 2025. The number of under 5 admissions also reduced. Please, for total major surgeries, the figure is not there, but it's supposed to be 24,021 in 2024, and then 23,883 in 2025. I got the figure after I submitted. And then for minor surgeries, it's 9,971 for 2024, and then increased rather in 2025 to 11,272. Deaths per admission rate also increased from 1.64 to 1.79. Those figures were late. Yes. Okay, so now we come to pharmaceutical care. And we tried to use the reporting format to elicit responses from the facilities. For this particular portion, we have a mixture of data source. The total prescriptions served per month was obtained from reports sent by 7 facilities, just to give us an idea of what happens on a monthly basis. We got it from 3 hospitals and then 4 polyclinics. And so on the average, it's about 36,510 for 2024 and 31,925. We hope that with the collection of data from other facilities, the numbers would improve, but at least we have a fair idea of what's happening on a daily basis. For insured clients, yes. And then the revenue, I was told that the figure for 2025 insured clients is affected by loss of 2 months data because of the LIMS. That is how come, and you are expecting an increment, but then we ended up with 99,211,601. Okay. And then please, let's move to the interventions. So for the interventions we got our information from 12 facilities. Amongst them are 2 CHAC facilities, 4 hospitals, 1 model health center, and then 5 polyclinics. So from these facilities, the 12 facilities, the total interventions was 3,977 in 2024, and then 4,959 in 2025. I'm sure that when we get feedback from other facilities, we are going to get more. That shows that at least pharmacists are picking up a lot of these. They are happening in the facilities, and pharmacists are picking them up, and that's good for us. So for the clinical ward activities, for the clinical ward activities, this one, data was obtained from 4 facilities, 3 polyclinics, and then 1 hospital. Now, when we look at the pharmaceutical care plan, according to the reports that came in, the reports were from 4 facilities, but 1 facility didn't have information for 2024. And so you see that the increment is the jump is high, from 19.75 to 38.75 for the pharmaceutical care plan. Ideally, it has to be done for every patient on admission, but because of the staff strength, it's not done for everybody. Now, the drug therapy problem resolved, according to the information we got, 31.25 in 2024, but then it's improved to 52.52. Then you ask, what happened? Is it data error? So we are going to look into that. But discharge counseling, we saw an increment from 85 to 128 in 2025. And for emergency medicines accessibility on the ward, putting information from these 4 facilities together, we had 68.25% 2024 to 94. We are hoping that in the coming year, at least, it would be 100%. And then probably when we get information from the other facilities too, there might be an improvement. Then we come to type of medication errors. For this one, we got information from 13 facilities, 2 CHAC facilities, 4 hospitals, 1 model health center, and then 6 polyclinics. So for the total the facilities gave was 3,223. And so the proportions have been given as such. And we could see that more of the medication errors were ascribed to prescribing errors. And the remarks that were given from the facilities were quite interesting. It gave us the impression that the pharmacists were really into what they were doing. One remark is prescribers were duly contacted and corrections were made. And then another facility said the errors were ranging from incomplete dosage regimen, dose to weight ratio, under overdose, rarely medicine mismatch. Then another also said prescription review, adherence to treatment guidelines and clarification with prescribers. So then that's what made them, that's when they picked them up, at least these were some of the things that they did. For dispensing errors, 0.13, that's a proportion. The remarks have also been given. Then administration errors were quite few. Then others was almost insignificant. So then that gives us our complete proportion of 1 when we put everything together. But the comments I would like to make on this is that medication errors, they continue to occur. We are being trained day in and day out. There's the Drugs and Therapeutics Committee, stakeholder engagements, everything, but they continue to occur. So we as pharmacists in the facilities would have to be very, very vigilant. Now, the outcome of medication errors. So most of it said no harm. And then the others just contributed just a bit to it. So for the remarks concerning the no harm, some of the remarks that came were usually errors are readily identified and immediately rectified so that they do not cause any untoward effects. And then overall medication safety measures are implemented and monitored. And then, so then there was no harm. Okay, so for deaths, I saw 2. And I know the facility. So I would find out whether it is something that actually happened or it was a data error. Now, for the source of adverse drug reactions, we try to get some feedback. So there was a total, and then like my other presenter said, we had to merge some of the classes. For example, for here, we had to put various and blood-forming organ medicines in the same place because the spaces was not enough. So there was a total of 266 adverse drug reactions from these 13 facilities I mentioned. And the greatest proportion is attributed to the class C drug, that's the cardiovascular drugs. And the comment there is that they will closely monitor the BP and heart rates, and then those titration also went on. And then for the nervous system too, I think it had to do with a neonate. So the comment there was near-death experience, error was rapidly corrected with naloxone and oxygen. For dermatological, almost it happened, but the proportion when you look at it, it was almost insignificant. And then when we come to the outcomes of the adverse drug reactions, please let's move on. Yeah, when we come to the outcomes, for 265 out of the 266, they didn't require hospitalization. And it was just 1. That's the unit, yes. So that one, that's the information for that one too. Okay, please let's move on. Yes, so we come to the rational use of medicines. Okay, so the total there should be, 266 instead of the 265. 266, yes. 266, yeah. So now we come to the rational use of medicines. Like I said earlier on, there have been much improvement. Is the antibiotics that was still hitting us. And then when we drill down, we are getting our upper respiratory tract and then UTIs. We pick this information from DIMS. Now for the non-DIMS indicators, we got the information from that complete information. Sometimes you review a report and then you see that just one of these indicators have been reported on. Please, yes. You see that just one of these indicators have been reported on. For example, all you see is the report telling you that percentage of drugs adequately labeled is 100%, but none of the other indicators have any results. So that tells you that the facility really didn't carry out this survey. So for the reports we got, 7 of them gave complete reports. And that is One Chuck Hospital. And then, yes, and then 3 hospitals and then 3 polyclinics. So the average consulting time for 2024 was 18 minutes, but it improved to 14 minutes. I mean, it's way above what the standard is. And then dispensing time was 5.6, 5.2, also higher than what is expected. Percentage of prescribed drugs that were dispensed, 86% increased to 90%. And we hope that in the coming years it's going to be 100%. Then the percentage of drugs adequately labeled, it's improved 97 to 98.62. We should be seeing 100% knowledge of correct dose and improved to 94.30. For this one, it's interesting because at least when you test the patient and the patient is unable to remember or recall what has been given, it's very serious. So in fact, it's something that we would have to look at. And most of the facilities to conduct this, sometimes we come to work and then our hands are just deep in what we are doing. We don't really look at the effects. Please, most facilities would have to be Let's go on. Please, let's move on. Okay, so pharmaceutical supply management and financing. So that's the information we have for the region. Our debt recovery rate was very low. In fact, from 69.97, ideally it should have increased, but rather we came down. So in the coming year, I think there should be much effort to improve on it. That's how come it's part of the regional priorities. And then continuation, closing stock. Yeah, our tracer medicines, there's the same question, whether there's a new list, because looking at the list, and then we picked our information from the RMS. So I don't know, but at least there was an improvement. It wasn't as much as we were expecting, quite marginal, but at least it can be improved with time. And just like other regions have presented, our health centers are holding the highest chunk of our monies, 46.80%. That's quite huge. So our debt recovery methods would have to be sharpened so that we can recover our money. Other than that, then we reduce the availability of ARMS. Now, the ATC classification, we have the information for 2024, still getting information for 2025. So then it's quite difficult to compare, but it's easy to note that at least the medicine or the class that is holding the chunk of our purchases, that's the anti-infective, was 24%, very high. And then it's followed by the mixture of other things. So when we get the 2025 one, it will make the comparison easier. Okay. So yes, our working capital is there. We verified it. And then achievements. Please, let's link on. Yes. Okay, so during the year 2025, we managed to ensure that all heads of pharmacy units were trained in the use of the standards and practice guidelines for pharmaceutical services. And then we were able to bring on board the farm techs who are heads of pharmacy units. They were also called in for a training. They were oriented on it. It's just that they haven't started using it to report. Maybe that is the next step that we would have to go. And then there was improved tracer medicines availability. As said earlier, marginal though, improved rational use of medicines indicators, marginal, with the exception of antibiotics, that is a challenge. Then there was improved supervisory role of pharmacists at the sub-district level. This is an initiative we started in 2025 with the support of our Regional Director of Health Services. And she empowered us, along with SMC, to improve our supervisory role at the sub-districts. There are pharmacists in the district hospitals. We don't have pharmacists at the DHDs. We don't have, and they are not very ideal. So when we got this empowerment, I think some pharmacists went down to the district, supervised their stock taking, supervised their inventory management, took part in some of their training and all that, and written reports. It was very good. The only challenge was the financing, because there are some districts that didn't have pharmacists in them because they do not have a hospital. Now the question was, how do you finance that? And even the districts that had pharmacists there, the challenge was who finances it. So that's still on the debating table. The DHDs were very helpful though. Some gave vehicles, some even paid allowances, and it was quite interesting for the pharmacists. They enjoyed the fact that at least the districts were recognizing them. And then sometimes you get a comment from your colleague pharmacist who is at the sub-district, who is at the district level, telling you that, hey, now our district director says that we have to go and then carry out supervision. They were quite excited. So that is it for our supervisory role. Then improved viability of the regional medical stores. In fact, we set out to ensure that we move from our previously our net worth was 26. We set a high ambition for ourselves to get to 40 million. We just got to 34, 35, and then we can, that's the room for improvement in the coming years. Then we participated in all statutory activities, and we were able to have 3 in-person pharmacist quarterly data validation meetings. In fact, the in-person meetings helped because it gave an opportunity for pharmacists to move out of their comfort zone, come and meet other people, interact. We had the presentations all right, but after the presentations, there were hand-holding sessions, learning of new things, after that, and they really enjoyed it. So it's something that has come to stay, and then we hope it will continue. Conclusions, yes, 2025 saw a few marginal improvements. We're expecting more improvements by the end of December 2026. Our recommendation is to improve on all indicators in the year 2026. So next steps, continuation of regular quarterly pharmacist data validation meetings, biannual meeting with pharmacy technicians to be instituted, improve pharmacy supervisory role at the sub-district level, improve availability of effective essential medicines, and conduct stakeholder engagement to improve the visibility of pharmaceutical services in the region. Thank you.
Thank you very much, Eileen. That was very detailed. I know most of us are getting tired, but we will take our last presentation and then we will all call it a day. So Chief Felix, Upper West, you are up next.
Thank you very much. Good afternoon. And I hope to be very brief so that we can all go and get the rest that we need. So in Upper West region, this is just a snapshot of what happened in the year under review, the year 2025. The total population at the beginning or in the year 2024 was 971,774. And in the year 2025, there was a slight increase to 995,502. So the landmass is the same. The number of administrative districts is the same as 11. The number of sub-districts, the same 75. The figures really don't made any changes except in the private and also polyclinic, there was a sharp increase from 4 to 21. The other figures basically remain the same. Then the total number of health facilities in the year 2024 was 1,026. Then it increased to 1,052. Okay, can we go on, please? So when it comes to governance and leadership, the region-specific challenges, so food facility indebtedness to the regional medical store, came a shortage of pharmacy workforce across the entire nation. Huge indebtedness to suppliers still remains. Then the whole year under review, we didn't. Hello, there's feedback from someone. Can somebody unmute? No, we the whole year under review, we did not have any procurement officer, and we had to manage like borrowing procurement staff from the regional and the municipal hospitals to come and assist us in the procurement exercises, and that challenge delayed most of our procurement activities. Then the Upper West region has annual meningitis outbreaks. And the government has also declared free treatment for these outbreaks. However, we don't get reimbursement concerning this. So it's like an annual ritual where certain medications need to be procured and to the community for free. Some facilities don't adhere to the last mile distribution and we just come to the medical stores on a lot of emergency that we have to attend to them. Then when you go across the facilities, there are poor pharmacy store infrastructure across the entire region. When you look at a place where they call the pharmacy store, you wonder how we are keeping our medication. They need infrastructure uplifts. So the regional priorities for the year 2025 was to improve essential medicine availability at the service delivery points. Actually, when the new regional director came around and he came in and we were going around, I was part of the team that went around, and everywhere that we went, there were stock out of medicine shortages, a lot of complaints. So we decided to improve availability, then carry out last mile distributions to all the service delivery points, then improve on rational use of medicine indicators across all facilities, Then improve on monitoring and supervision of pharmaceutical activities in the year under review. Then we also wanted to reduce medication errors through effective drug and therapeutic committee activities, and also improve government hospitalization rates. At the year 2024 saw our rates going really very down. So those were our priorities. The year under review did not see any pharmacist or pharmaceutical staff complement, the mechanized one. Can we go down? For senior specialists, we have actually 5. Instead of the number at post is 5, not 4. One got his documents and everything. So we require 20, we now have 5, and the gap is 15. Pharmacists, 87, required 20 at post, a gap of 67. Pharmacy technician, 250, required 62 at post, a gap of 188. Dispensing and medicine counter assistants, we are not requesting for any of them. So in total, we require 357 pharmacy workforce. We have only 86 at post, and we have a gap of 271. Okay, can we go on? On the non-mechanized, we have only pharmacy technicians, 36 who are. We are trying to leave the mechanized to relieve the revolving drug fund of their salaries. So when you look at the pharmaceutical staff complement, that's the mechanized and non-mechanized, the total staff is 357, number at post 122, and they have a gap of 235. Can we go on? So these are the key clinical services indicators. The OPD visits in total in the year 2024 increased from 995,000 to 1.1 million. The OPD visit per capita increased slightly from 1.01 to 1.06. The OPD visits per insured clients also increased slightly from 877,000 to 1 million plus. Total number of admissions also increased just slightly from 86,727 to 86,932. Total number of infant admission, we do not have the figure for 2024, but for 2025, it was 8,912. Total number of under 5 admissions also in 2025 was 19,218. Total admission rates decreased from 89 to 81.58. Total major surgeries increased significantly from 1,718 to 6,344. Total minor surgeries remain almost the same at 2,000. Total number of patient deaths decreased significantly from 1,913 to 408. And deaths per admission rates also reduced subsequently from 2.2 to 1.87. Now, on the pharmaceutical care indicators, when you look at the total number of prescriptions sold comparing 2024 to 2025, 2024 saw 326,019, and there was slight increase to 351,759. Average prescription sold per day also increased from 800 to 900 plus. Insured clients also increased from 74,000 to 77,000. Then the revenue also increased from 3.5 to 4.9 million. The non-insured out-of-pocket payment also increased from, the number was 9,841 to 16,436. And non-insured out-of-pocket payment rather that decreased from 8 million to 5 million. And total interventions for the year 2024 was 138 and increased to 240 in the year under review 2025. So, clinical ward activities, we could not get the data for 2024, but for 2025, the percentage of patients that had complete pharmaceutical care plans was 35. The percentage that drug therapy problems were resolved was 98%, and discharge counseling was done for 85.7% of them. Can we go on, please? So, emergency medicine availability in the year 2025 was 73. Okay. Patient safety and quality improvement. Type of medication errors. Prescribing errors. We had a number of 216 representing 90%, dispensing 12 representing 5%, administration of medication. The number was 12, the same 5%, and the others, there was 0. So the total of 240 was observed, representing 100%. The outcome of medication errors. So there wasn't any harm in all the 240, that was 100%. The source of the adverse drug reaction. According to our ATC classification, the anti-infective for systemic use, we had 2, representing 14.3%. Then anti-parasitic products and insecticides, we had 6, representing 42.8%. Nervous system, we had 5, that is 35.7%. And various, we had 1, representing 7.1%. Can we go down? Can we move on? Yes, thank you. So a total of 14, that is representing a proportion of 100%. The outcome of the adverse drug reaction, all the 14 recovered. So rational use of medicine service indicators. Basically, all the indicators improved from 2024 to 2025, the year under review. The average per prescription reduced from 2.7 to 2.6. Generic name increased slightly. Those that were prescribed with written antibiotics decreased from 40 to 32.1, and all these indicators were pulled from the DIMS. Injections decreased from 7.2 to 6.8. EML increased from 95 to 97. Average OPD consulting time increased from 12 minutes to 20 minutes. Average dispensing time at the OPD also increased from 13 minutes to 19 minutes. Average number of drugs that were dispensed also increased from 89% to 98%. Percentage of drugs adequately labeled was from 96 to 98%. So percentage of patients with knowledge of correct dosage also increased from 98 to 99%. So there was slight increase. Now, pharmaceutical supply chain management. In the year under review, in 2020, we did not have any framework supplies. All the framework suppliers did not supply us because the prices were not good and the distance was long and the roads were bad and all that. But the year under 2025, the year under review, they supplied us 6 million worth of drugs. Non-framework, we got 9 million in 2024 and 15 million in 2025. Significant increase. So the total purchases in the year 2024 was million. In the year 2025 was 21 million. So that was double. Like regional director said, we should work together to make drugs available, as they were complaining of stock out, a lot of stock outs. So annual sales likewise increased from 2024 from 14 million to 2025, 21 million, almost doubled. However, the total receipts or payment we received from the facilities was 11 million in 2024 and the same 11 million or even slightly a reduction, 11.5 million in 2025. Payments of vendors also decreased from 11 million in 2024 to 9.6 million in 2025. Total debtors jumped from 22 million in 2024 to 32 million in 2025. And this debt recovery rate that I have put there actually is not the correct figure. In 2024, it's 123, and 2025 is 52%. Actually, at the end of the day, I would like us to come to terms with what formula we are using to calculate this debt recovery rate, because I given this and they gave me different figures. I saw Gemini and DeepSeek use statistics. They also came on figures all together. At the end of the day, I was confused. However, the Gemini formula be the reasonable thing. And one, the debt recovery rate for really, but then statistics are giving different, the same variables. So I think it's really the acceptable one. But what the actual figures say? Okay, can this? So summary of operations of the regional medical stores. Stock in 2024 was 8 million and in 2025 was 12 million. There was an increase. Cash book balance at 443,000 in 2024, but at the end of the year 2025 was 1.7 million. Total creditors was 12 million, and in 2025 was 26 million. Net worth increased from 17 million to 20 million. Actually, looking at the 3-year trend from 12 million to 17 million to 20 million, almost doubled within 2 years. So tracer medicine availability, there wasn't any increase. It was 73.3% and remained so in the year under review. So debtor schedule by facilities. This is where it becomes very interesting. For the hospitals and polyclinics, they are owing 12 million, representing 39.9, which is almost 40%. The DHDs alone, when they stand alone, the district health administrations, they are owing us just 6,524, representing just 0.02. The health centers are owing 3 million, representing 11%. And the chips are owing 13 million, representing 40%, which is the highest among the debtors. And non-Ghana health service facilities are owing 2 million, representing 7.91. So a grand total of debts, as I said, was 32 million, which is representing 100% of the debt. Then analysis of pharmaceuticals by class and values. Can we please go on? Yes. So the alimentary tract and metabolism in 2024 purchased 2 million. In 2025, it's just about 2.2, a slight increase. And in 2024, it represented 21% of total procurement. In 2025, it just represented 10%. So the percentage also by rank, it was the first in 2024 in terms of value, but 2025, it was the fourth. It declined about 4 points. Can you move on slightly? Can you move? Yes. Then the blood and blood forming organs. So the purchase from 2024 was 1 million, 2025 was 5 million. And it jumped from being third it became the first product in terms of value. Then cardiovascular systems. In 2024, we bought 646,000. In 2025, we bought 395,000. So it moved from the rank of 6 to the rank of 10 from 2024 to 2025. Dermatologicals, we bought 457,000 in 2024, and we bought 378,000 in 2025. So in 2024, the percentage was 4.7%. 2025, it just 1.7%, moved down the ranking from 8th to 11th. I think the rest are all there, as we can see. The L, which is the anti-neoplastic and immunomodulating agents, we have not been procuring anything, and it's been at the last part. So the 2024-2025, it was still 0, 0, 0, 0. And the rest are all there. If I go through all of them, it will take a lot of time. Okay, can we go on? So expired products are also attached here from medical stores, which are yet to be disposed. They are working on it to dispose of it. So the working capital from 2024 to 2025, like I said, was 17,984,442 in 2024, and it increased to 20,052,554.54 in 2025. Then achievements. So 5 rounds of last mile distribution were carried out by the RMS, and we improved drug availability at the service delivery points. Over the last year, like I said, we increased the drug we distributed from 11 million in 2024 to 21 million in 2025. And all adverse drug reactions and medication identified were successfully resolved and reported to the FDA. We improved Gilmer's utilization rates, which was also our target, from 20% in 2024 to 83% in 2025, which was a huge jump. The year under review, we were able to install some CCTV cameras at our regional medical stores, bought new air conditioners, laptops, and improve their operation. Then all the rational use of medicine indicators improved, with antibiotic prescribing, which was a challenge, decreasing from 40 to 32%. Then proactive intervention of having adequate ceftriaxone injection and infusions, and ahead of the meningitis season, so that this year we did not have any outbreak of meningitis, though throughout the entire season. We made sure that the products were at the service delivery points and they were used before the meningitis cases started coming in. So in conclusion, the year under review saw a relatively improved drug availability as well as improved rational use of medicine across all health facilities. Although there were few pharmacy workforce and burnout was high, with high active rates, staff morale is high, and they are delivering their best to support pharmaceutical care in the region. More staff are needed for the successful implementation of the standard and practice guidelines of pharmaceutical services. And the recommendation are urgent need pharmacists and pharmacy technicians to be posted into the region to optimize delivery of pharmaceutical services in the region. Then monitoring and supervising of health centers and CHIPs to support to supervise and mentor them on their drug record keeping and the revolving drug fund management, and change the trend in high RMS indebtedness and strengthen debt collection exercise. Actually, I had a discussion with regional director when we reviewed this data, and I advised him that looking at the trend of trying to supply more drugs and not be able to recover the debt, we needed to be more robust in our debt collection exercise. And indeed, this year we have done one, and even tomorrow I've seen a letter that tomorrow we are also carrying out another debt collection exercise where we invite the MESUPs and their teams here, and we meet with them here of insurance payment, which we have had. And so tomorrow that exercise will be carried out for all hospitals and polyclinics, and we are being robust to recover the debts Other than that, we can't go on distributing high volumes of medicine without recovering the cost. So the next steps, quarterly pharmacy review meetings to validate data and address challenges will still be ongoing. We'll improve on procurement practices and make them available at the service delivery points, improve on monitoring and mentorship and supervision of all facilities, especially the health centers and CHIP compounds to support their drug management, strengthen DCT activities to reduce medication errors and improve patient outcomes, and train pharmacy heads on the standard pharmaceutical service reporting. For some of the reports, when they come in, you just can't align it. It becomes difficult. So I think they all need training on the reporting format so that they can all report adequately and appropriately. On that note, thank you very much for your attention.
Thank you very much, Chief Ellis, for wrapping up for us beautifully. Thank you to all our presenters for today. All the chiefs that presented, we are most grateful. For the last batch, the 3 regions that presented the last batch, please, the floor is open for questions for them, contributions, comments, anything you want to put across is welcome. Thank you. I know we are all tired, some are hungry, but can we ask our questions so that we can wrap up for today?
Auntie, now if they are not asking me a question, can I ask one question?
Yes, please, go ahead.
Yes. What is the recommended or acceptable formula for calculating the debt recovery rate? Because as the facilities are presenting, when I look at the formula, the data they have provided and the debt recovery rate that have been put there, I'm having challenges with them. So if we can have clarity on that one, because if the AI in the same data or variables.
Okay, Chief Poku, we will respond to that. But before that, Chairman Obiafe.
Okay, yeah, thank you very much, and good afternoon once again to my directors and chiefs. Yeah, so I want the question is to the last presenter. He indicated that through the rational use of medicine survey, there was marked improvement in the percentage of prescriptions that had antibiotics prescribed. I wanted to find out what specific interventions he and the team put together, I mean, within the period in question that has accounted for the reduction in the antibiotic prescriptions. Thank you.
Thank you, Chief Ellis. I hope you took notes. But let's note Central Region presented and then Bono East also presented. So please, any question for them as well? And Bono East. Okay, if there's none from our members, Director has a few comments and questions to ask. The floor is
open. Thank you. To the presenters, let me thank you so much for the good breakdown. Chief Ellis and Chief Poku, if you had given the fact that they just already reassigned, I would have asked you to stay in your region for this 3 years. But, okay, let me begin with the question Chief Ellis asked in relation to debt recovery rate. Debt recovery rate, simply put, is the proportion of debts recovered in the course of the year, during the year under review. And the formula is the total debt recovered or received divided by total sales times 100. So in the course of the year, if you sold good worth 1,100,000 Ghana cedis, and you recovered 50,000 out of it. The recovery becomes 50,000 divided by your total sales times 100. That is 50% recovery. So simply put, that recovery rate is proportion of debt recovered during the period. Thank you. Having said that, Central Region, you didn't give us your procurement of medicines by value using the ATC classification. Can you tell us why it was so? Because we didn't see that. And that is very disturbing. You know, that is the reason why administrators think that they can take over management of pharmacy stores. Time has come that we must start adding some professional touch to the work that we do. So, Senator, can tell us why they did that. I also realized most of us did not, all of us did not give us the amount of money we spend in paying our casual workers. That figure is also important, so that at the headquarters level, we can put all the figures together to know how much money is going to payment of casual workers from the revolving trust fund. But for me, it's a very critical thing to look at. If so much money is paid out of the revolving trust fund, then we can be sure that in no time, the funds will completely dwindle and will be out of stock when it comes to medicines. So going forward, we expect the at least give us, if you have casuals, please let us know how much we are spending on them from a revolving trust fund. I also realized that some regions were giving us the number of non-mechanized staff required. No, we're not supposed to do that. You see, the non-mechanized staff is basically meant as a stopgap measure for the mechanized staff. So ideally, what we expect is that if you give us your mechanized staff, then the gap that you have in your mechanized staff is what you expect the non-mechanized staff to be filling. So don't write there again that we require a non-mechanized staff of this. That's what I don't tell everyone. No. So give us your mechanized staff, state the gaps there. Then tell us how many non-mechanized staff we have recruited to fill in the gap. But don't write the number required. No, we don't want that data for now. Let me also commend Chief Poku for the good work done, at least trying to strengthen rational use of medicines in your region. Your REM survey results were so much impressive, and we'll be very happy if you can share your best practice. Thank you very much.
Thank you very much, Director. I think I will, Jocelyn, I see your hand up, but I will want the Chief to respond before we take your questions. So Chief Eileen, can we start from you?
Yes, please. Please, Director, like I said, thank you for your question. Like I said, it's being compiled. The officer working on it said she had a challenge with her computer. So please, when we get it, we'll send it so that we can have a good comparison. Thank you.
All right, thank you.
Auntie Edna, can I come in?
Yes, please.
Yeah, thank you very much. So for Bono East, we saw that our antibiotic prescribing was escalating. So initially, I wanted to have a research, but I got to know from the health information that it was the private facilities that were prescribing those high figures. So I went to them. I think for some of the facilities, I went to them twice. And to them, like, as if it was like you prescribing the EML and the generics, you should go to 100%. I said, what? So I schooled them, and they got to understand, some of the figures were just being cooked. But for the Ghana Health Service pharmacists, I think we had in-service training and we discussed. So they were okay with that. They talked to their prescribers. They had meetings with them during their meetings and were able to resolve some of them. So that's how we went about it. Thank you very much.
Thank you, Chipofu. Please.
Okay, thank you. Can I come in?
Yes.
Yes, Dr. Rafi, thank you for your question. About the antimicrobial coming down, utilization coming down in the region. I also use this strategy when we were doing the training on the guidelines of pharmaceutical care. We had a presentation microbial stewardship. Our regional hospital is a center for antimicrobial stewardship. So from that was available to also orient all the present pharmacists on antimicrobial stewardship. And I think that went a long way. Secondly, when we are also doing our review meetings, we always come up when they are bringing their data and we are discussing. So it's continuous reminders and training that has brought our figures down. Thank you.
Thank you for that explanation. I hope Chairman Oyafi are okay with that. Please, I would like to call Jocelyn. Jocelyn, your hand was raised, but now it's down. I don't know if.
Okay. So this is Jocelyn. In fact, mistakenly it was raised, but then I think I want to commend Director and his team for this insightful meeting. I've really enjoyed it. It's the first of its kind, and I'm happy that we have it on board now. And I'm sure it will go a long way to also help us wherever we find ourselves in the work that we do. So thank you very much.
Thank you, Jocelyn.
Hello.
Yes, thank you. Any more? Well, on that note, we want to say a very big thank you for staying on with us till this time. And looking at the time, we are tired, so I will hand over to Director to give us a closing remark. Okay. Director's closing remark will come tomorrow after the program. So we want to say we appreciate your time and the efforts for the presenters, for the excellent presentations you've made, for all the questions that came and the contributions that have come on board. We've taken note of everything, and we want to once again say thank you. We continue tomorrow, same time at 10 a.m. and we'll be finishing tomorrow. Tomorrow we have the big shots, the big regions. Some of them, I think we had just a couple of them present today. Most of them are presenting tomorrow. So please make it a point to log in and participate fully so that we can have a very fruitful performance review. Thank you all for coming, and we will take a closing prayer by the same person who prayed in the morning, and then we will end it. Dr. Osu.
All right, thank you, Dr. Edna. Shall we pray? Father, in the name of Jesus, we thank you for a very successful meeting. When we were beginning, we called on you, and indeed, we have seen that you were with us throughout this meeting. Very good presentations, and very good lessons to learn from. We pray, God, for the wisdom and then the knowledge to be able to manage some of the issues and challenges that have been raised, so that pharmaceutical services shall ascend and move forward and make very great impact for the nation and for the people of this country. We thank you. We commit even tomorrow's program into your hands. We pray that you will be with us, and we pray that everything shall be successful. We thank you, give you all the glory. In Jesus' name, amen.
Amen. Thank you all for coming. Have a wonderful rest of your day. Thank you.